So, hi guys, good evening. Let me just check whether I am audible and visible to you in a proper manner. Yeah, hi. I hope I'm audible and visible to you in a proper manner. Okay, so just give me a thumbs up if I'm audible and visible to you. Okay, that's great. That's great. Okay, right. So, guys, yeah, uh, really good to have all of you with me in this particular session. Today, what we are going to do is we are going to revise the important PYQs which we had for the last three or four kind of sessions. Whatever the important PYQs which we had, we are going to revise those. Okay, so that's what we are going to do. Okay, now I'll try my level best to provide the maximum value to you guys, and I will be like trying my level best to kind of do justice to whatever this particular task has been assigned to me. Okay, now before I proceed with this particular kind of session, I just want to share a couple of things with you guys. Okay, so first and foremost, whatever the questions are going to come in your surgery, like in this particular exam, I'm pretty sure that 70 to 80% of them will be from the very simpler topics. So give them adequate time and don't do or try to reduce your silly mistake in those particular topics, because that is what is going to help you a lot in kind of increasing your kind of permanent marks and all those particular things. Okay, so what we're going to do, I will just start with this particular session, and in the midway I will share a couple of exam tactics with you and all. So let's quickly start with this particular session. Okay. Right. So the first question which we have is, the following ulcer is seen in which condition? Okay. So here what you have to notice is that what is the location of this particular ulcer? So can you see what is the location of this particular ulcer? This is basically located on the lateral aspect of the kind of the foot. Okay. So it is basically present on the lateral aspect of the foot. So can you please tell me what is this type of an ulcer? Is it like a malignant ulcer, arterial ulcer, venous ulcer, or a trophic ulcer? Can you please hear back from you guys? Like, what do you think? What is the answer over here? Okay, so the answer to this particular question is definitely an arterial ulcer. So let's kind of quickly cover about these particular things, right? Okay, so what you need to understand is that, let's say if at all they give you a scenario that there is a patient who is having a long standing non-healing ulcer, non-healing ulcer, and if at all they ask you what is the next step, okay, what is the next step in the management of this particular patient, what is the next step? It is a biopsy. Okay, what you have to perform is a biopsy. Why do you want to perform a biopsy? First of all, what is this long standing or a chronic ulcer? What is a chronic ulcer? How do you define a chronic ulcer? Period of more than 3 months. Okay, so if at all there have been a period of more than 3 months, this is like, what is the next step which you have to perform in these particular patients? You have to perform a biopsy. Why do you want to perform a biopsy? Because you want to rule out the malignancy. Okay, so I hope that you understand what I'm talking about over here. So I'm basically trying to talk to you about the Marjolin's ulcer. Okay, so if at all they want to kind of give you about the Marjolin's ulcer, so this is one of the important clinical scenarios which they keep on giving, that there is a long-standing non-healing kind of an ulcer. What is the next step in the management? It is the biopsy. Why? Because you want to rule out the malignancy. Which malignancy? The Marjolin's ulcer. Now, if at all they want you to mark as a Marjolin's ulcer, they are going to give you that there is a post-burn contracture, and there is an ulcer which is kind of not healing for more than 3 months. This is what they're going to give you. And another thing which you need to understand, when you perform a biopsy, what is the histopathological type of this? So this is a low grade squamous cell carcinoma. Okay, so this is what you need to understand about all these particular stuff, right? Okay, so the malignant ulcer, essentially what they're basically trying to talk to you about the malignant ulcer, they're basically is the what you call as a Marjolin's ulcer. Okay, so I hope you have understood that is not the answer over here, but this is what is a Marjolin's ulcer. Then arterial ulcer, whenever they, okay, so if I ask you which is the most common site of the like arterial ulcer, one, which has been shown in this particular kind of an image. So this is the lateral aspect of the foot. That is one. What is the another kind of a thing? Another thing is the tip of the fingers. Okay, so usually the tip of the great toe. Okay, so tip of the great toe. So these are the most common sites of an arterial ulcer. Okay, and in the arterial ulcer, this is basically common in the PVD patients, peripheral vascular disease patients. In this, there will also be certain skin changes. They will give you certain skin changes as well. So what are the skin changes which they are going to give you? They are going to give you that there is a loss of hair. They are going to give you that there is a thinning of the skin. Okay, so these are the things which they are going to give you in these particular stuff. Okay, so your tip of the toe, very nice, certain. Okay, right, understood. Now what about the venous ulcer? Who is going to tell me that what is the most common site of a venous ulcer? Venous ulcer, which is the most common site of a venous ulcer? Most common site of the venous ulcer. Okay, so the most common site of the venous ulcer is the gaiters area. Okay, what is it? It is gaiters area. What is this gaiters area? Gaiters area is basically present on the medial aspect of the lower leg, lower 1/3. Okay, so medial aspect of the lower leg, yeah, it is a medial aspect of the leg, lower 1/3. Okay, so in the medial aspect of the kind of a leg, lower 1/3, this is what is a gaiters area, right? I hope you have understood this particular point. Now, lastly, before moving ahead, I want to just discuss about the edges. So what is an edge of a venous ulcer? The edge of a venous ulcer is a sloping edge. Okay, so what do we have? We have a sloping edge in the venous ulcer. What about the edge in the arterial ulcer? What about the edge in the arterial or a trophic ulcer? It is basically a punched out. Okay, so punched out edge is something which you basically find in the arterial or a trophic ulcer. Okay, so I hope you have understood. These are the important questions which they can ask you from the ulcers. Okay, got it? It's not everted, it is a sloping edge. Okay, sloping edge is basically present over here. So everted edges are basically present in the squamous cell carcinoma. Okay, everted edges are in the squamous cell carcinoma. Rolled out edges are basically in the basal cell carcinoma. Please understand this particular. Okay, right? Okay, good. Now let's move on to the next question. Pretty simple question, nothing like very significant about this. So there's a 35-year-old male patient who has been brought to the emergency room after the road traffic accident. After the head injury, the CT scan of the patient was done. What is the most probable diagnosis? It's practically a giveaway question. So what is this? It is basically an extradural hemorrhage. What are you basically finding over here? You're basically finding a biconvex opacity. So what are you finding? You're finding a biconvex opacity, and that is why what is the diagnosis over here? It is an EDH, extradural hematoma. Okay, so what is the diagnosis over here? EDH, extradural hematoma. Okay, now I'm pretty sure that all of you might be knowing this particular CT scan. If not, please kind of go through this. This is one of the simplest questions which can be asked to you from the surgery in this particular exam. Okay, now let's quickly cover important things about the EDH. If I ask you that, okay, I hope that everybody understands that there is a fracture at pterion. So what is this pterion? Pterion is basically the thinnest part of the skull, and just below this particular pterion, what is going? Just below this, okay, just below this, what is basically going? We have the middle meningeal artery. Okay, now this is something which you might not be aware of, but if I ask you, you please put it in the comment box. So this middle meningeal artery is a branch of what? Okay, so just if they want to ask you a, let's say, a clinical anatomy correlated question, they can ask you this. Okay, so this middle meningeal artery is a branch of what? Okay, just put it over here. So yeah, that is why we understand that this is an arterial bleed. What is present associated with this? We have something which is called as a lucid interval. So what is this lucid interval? That is like after the road traffic accident, what happens is that the patient basically collapses. Then over a period of time, then the patient becomes conscious. Then after some period of time, the patient again basically collapses. Are you understand my point? So this period of consciousness, between the two episodes of unconsciousness, this is what is referred to as your lucid interval. Yes, absolutely right. Maxillary artery. Very nice, very nice. Shelly and yeah, a couple of you guys have answered. So this is basically a branch of your first part of maxillary artery. Okay, this is a part of your first part of your maxillary artery. Okay, great, good. Okay, now what about the lucid interval? We have talked about the lucid interval, that's fine. Now another important thing which you need to understand over here in the EDH, what you need to understand is that the blood does not cross the suture line. Okay, so why this is so? I hope that you remember that, you know what, that is the suit, like this particular dura is basically densely adhered at the suture line. Okay, so basically because the dura is very, very densely adhered, the blood doesn't crosses this particular suture line. But on the other hand, in the subdural hemorrhage, okay, so in the subdural hemorrhage, this particular blood, this crosses the kind of a suture line. I hope you are able to understand this point. This is again an important thing which you need to understand over here. Okay, now rest all is fine. What about the CT scan? We talked about the CT scan. What we get is a biconvex opacity, and yeah, that is what you need to understand. What about the management? The management is basically the burr hole. Okay, so the management is either a craniotomy, guys. Okay, what is the CT scan finding in the patients with the SDH? Yeah, so it is what you call as a concavo-convex, or a what you call a crescent shaped opacity. Okay, so yeah, that's what you basically get over here. As you can understand, this is because of the vein. So this is what is your venous blood. But in the EDH, what do we had? We had a arterial blood, which was basically coming out over here. What you need to understand is that yeah, so here what you need to understand is that the blood is going to cross the suture line. Okay, so in the SDH, the blood crosses the suture line. Okay, so blood basically crosses the suture line. Okay, I hope you have understood this particular point. Okay, now before I move ahead on the SDH, I'll just answer this particular doubt, which is a very valid doubt. So I'll just kind of answer this particular stuff. So Vidhi is basically asking, sir, where is burr hole made? Site to be chosen, like how do you kind of choose it? So what you need to understand is that whenever there is a EDH present in this particular patient, any particular patient, what it basically causes is, it basically causes, okay, what happens to the pupils? Do they get dilated or do they get constricted? So if at all there is an EDH which is happening, what you need to understand, there is a pupil dilatation which takes place, and what happens? There is a weakness of the lower limbs. Now, who is going to tell me that this pupillary dilatation is taking place on the same side of the EDH or the opposite side? So please try to understand this is on the same side, or ipsilateral. What about the weakness of the lower limb? This is basically on the opposite side, or contralateral. Okay, so now you are able to tell me, right? So because what you need to understand is that the pupillary dilatation is on the same side. So when you kind of check with the torch, and if at all the pupils of the right side are dilated, you have an understanding that there is a right-sided EDH. And now what you're going to do, you're going to kind of do a burr hole on the same side. Are you understanding my point? Now, if I just give you, this has been asked to you in the previous exams. So if I ask you that, you know what, bilateral pupils are dilated, then what you're going to do? Are you going to do a central burr hole, or what you're going to do? So please try to understand, if at all bilateral kind of pupils are dilated, you have to do the burr hole on both the sides. Okay, you have to do a burr hole on both the sides. Okay, I hope you understood this point. Now, just one food for thought. Have you ever heard of Kernohan's notch? Okay, what is the Kernohan's notch? Okay, what is this Kernohan's notch? So what happens is that if at all there is a peduncular herniation is basically taking place. So if at all there is a uncle herniation, okay, so uncle herniation, if at all it's kind of there, and in the late stages of this, what you need to understand is that it compresses the descending pyramidal tracts of opposite side as well. So because of this, in the Carnot's notch, what you basically get, you get the weakness of lower limbs on the same side, and this is what is referred to as your false localizing sign. Okay, what is this referred to as? This is what is referred to as your false localizing sign. Are you understanding my point? Now these are the important things which you need to understand over here, guys. Okay, so yeah, this is important. I hope you have understood the question which was asked by Vidhi. I hope you have understood this. Okay, right. Now moving on to the SDH, I give you a scenario that there is a, now you have to tell me the diagnosis, guys. Okay, so let's say there is an 80-year-old person who basically fell from a chair. So he basically fell from, let's say, chair, or you can take anything. Okay, so let's take the patient fell from the chair. Now after the kind of accident, the patient was fine, but there was a slow and gradual deterioration of the functional and mental status of patient over 2 to 3 weeks, over 3 weeks. Okay, now the patient has been brought to the hospital. I want two things from you guys. Okay, what is the diagnosis and what is an investigation of choice? Can you please help me with this? Okay, so what are you kind of dealing with over here? What is the diagnosis and what is the investigation of choice? Okay, so yep, can you please tell me? Okay, so I hope that you're answering that the diagnosis of this particular patient is a chronic SDH. Okay, so the diagnosis is a chronic SDH. Yes, absolutely right, Sheetal. And what is going to be the investigation of choice in this particular patient? The investigation of choice in this particular patient is going to be MRI. Okay, please try to understand. It is not a non-contrast CT scan, guys. Okay, so the investigation of choice over here is an MRI. No, it is not a non-contrast CT scan. It is an MRI. In the chronic SDH, it is an MRI, which is the investigation of choice. See, please try to understand, guys, that why is the non-contrast CT scan investigation of choice for any particular head injury? Okay, why is a non-contrast CT scan investigation of choice for like all the head injuries? The reason is because what you need to understand is that is an acute extravasated blood. Okay, so an acute extravasated blood, acute extravasated blood, this appears white. Okay, now in the chronic SDH, what happens over a period of time, the extravasated blood, it loses its paramagnetic property, and over a period of time it becomes very, very difficult to distinguish between the what you call as a extravasated blood and the brain parenchyma. That is the reason why in the chronic SDH, okay, in the chronic SDH, what is the investigation of choice? Please try to understand over here. The investigation of choice is your MRI. Please do not mess this up, guys. Okay, it is a initial investigation, everything. It's like MRI. Okay, if at all you suspect a chronic SDH, you should get a MRI in these particular patients. Okay, I hope you're able to understand this point. Okay, now if I last question from this particular head injury, I give you a clinical scenario. Everybody have understood this, guys? I hope you agree with me. Okay, so I can explain it to you in a bit more details and everything, but see, guys, I'm trying to rush up because I value your time. Like 2 days before the exam, you are here and listening to me, so just want to provide the maximum kind of what you call as yeah, whatever the things I can provide to you. Okay, but if you still do not understand, please put it in the comment box. I'll give due time and I'll explain to you, but please take it from me. Investigation of choice for the chronic SDH is an MRI. Okay, I hope you have understood this point. Okay, now I give you a clinical scenario over here. I give you that there is a patient who suffered from a road traffic accident. When the patient came to the hospital, the GCS of this particular patient was 7/15. Obviously you will suspect that there is some massive head injury, so you performed a non-contrast CT scan in this particular patient, but to your surprise, it came out to be normal. Okay, so this is a clinical scenario. What is the diagnosis of this particular patient? Can you please help me? What is the diagnosis of this particular patient? Yep, what is the diagnosis, guys? What is the diagnosis? Sheetal, I'll get back to you. Okay, what is the diagnosis over here, guys? Can you please help me with this? Okay, so the diagnosis over here is a diffuse axonal injury. Okay, so answering the question of the Sheetal. So yeah, MRI is an investigation of choice for chronic SDH and diffuse axonal injury. Okay, diffuse axonal injury. Over here, also the investigation of choice is an MRI because your non-contrast CT scan is going to be absolutely normal. Okay, I hope you have understood this particular point, guys. Yeah, everybody understood this point. Now, lastly, if I want to ask you, what is the head injury which is having the best prognosis and which is the head injury which is having the worst prognosis? So, head injury which is having the best prognosis and the worst prognosis. Worst prognosis. So, the best prognosis is basically with EDH. And the worst prognosis is basically with the diffuse axonal injury. DAI is basically diffuse axonal injury. Okay, yeah. So, okay, Shimo is asking when chronic. Okay, so please try to understand if at all. Okay, now everybody have understood, right? Okay, now Shimo to just try to understand this. Okay, so let's say if at all I am traveling with a bike and I suffer with an accident, what is going to happen? I will have whatever the bleed or anything and I will be taken to the hospital. Immediately my GC is going to kind of go down. But in these particular patients, in the 80-year-old people, so what is the difference between the brain of an 80-year-old and you? The difference is that the 80-year-old man or female, whatever, the brain has become atrophic. Okay, it has become atrophic. So what is going to happen even with the trivial injury? For example, I fell from the chair, nothing is going to happen, right? Nothing is going to happen. Everything is going to be fine. But in these particular patients, what happens is that even with the trivial injury, there is maybe a slight bleed which starts into the brain. Okay, and the patients immediately have GCS, which is absolutely normal, but there is a slow and gradual deterioration over a period of 3 weeks. So somebody has rightly said that in the 21 days. So the patients present after 2 to 3 weeks, 14 to 21 days later. That is what is going to give you the clue of a chronic SDH. So old patient who had a trivial trauma, and after the trauma the patient was fine, and after that there is a slow and the gradual deterioration over the period of 3 weeks. All these particular things are going to prompt you to tell you that, you know what, it is a patient with a chronic SDH. Okay, I hope you have understood, right? Okay, now without wasting any further time, let's move on to the next question. A 50-year-old male patient is posted for the cardiac surgery. What is the preferred drug for the antibiotic prophylaxis in these particular patients? Okay, so what is the preferred drug, guys? Now I will not waste your time. You can take your guesses and all. The answer over here is a clindamycin. Now these kind of questions are once in a time kind of asked questions. Okay, so this is basically from your table which is given in the Sebastian. As you can see over here, for the cardiovascular and the thoracic surgeries, what you need to understand, clindamycin is basically used as a prophylaxis in the scenario of the penicillin allergy. Okay, so yeah, so what you need to understand, the primary thing over here will be penicillin. Okay, so you can use a penicillin. The primary thing is going to be your penicillin. But if at all they say that, you know what, if at all there is a penicillin allergy, then in that particular scenario you can mark it as a clindamycin. Okay, so I hope you are able to understand this particular point. Now I don't understand, or I don't know what were the actual kind of options over here, because again these are all the recall questions, guys. Okay, so I don't understand what were the options or something like that. But see, whenever the questions like these comes, the recall is always a bit dicey, right? But you need to understand from where this particular question was asked, and now you can kind of go ahead and read that particular source in detail, so that if at all that same concept is kind of tested again, you will be able to kind of mark in a better manner. So please try to understand over here that you can go through this particular stuff. Appropriate cephalosporin kind of prophylaxis for the selected type of a surgery, alternative prophylaxis in the serious penicillin allergy, and over here they have given you that in the cardiovascular and everything, they had kind of given you the clindamycin. So I don't know whether the penicillin was given in the option or not, but if both are given in the options, then probably you'll have to mark for penicillin. But if at all the penicillin is not given in the option, over here it's going to be a clindamycin. Okay, now over here, lower limb amputation in case of a peripheral vascular disease, over here you go ahead with the gentamicin and the metronidazole. Okay, and you can just go through the table and all these particular things are going to be there. Okay, now it is not related to the infective endocarditis. Infective endocarditis is completely different. So that is in your medicine, right? For there, what is the prophylaxis which you give? This is in general, like before any particular surgery, we give the antibiotic prophylaxis, right? So 1 hour before the surgery, we have to give a prophylaxis. So we are talking about that particular antibiotic over here. So this is basically in every individual. It is not just for the infective endocarditis or anything like that. Okay, I hope you have understood this particular point, right? Okay, right? So you can just go to this particular table, and this was the source of whatever the question which was asked to you. Okay, now this is again a very important concept for you guys. A lady with a varicose vein has an eczema. What is the stage of the clinical classification of the CEAP? Okay, so what is this particular stage of the clinical classification for the CEAP, guys? Can you please help me with this? What is the answer over here? Okay, what is the answer over here? Yep, the answer over here is C4A. Okay, so yeah, now let's talk about the CEAP classification. Now I understand that you might have kind of gone through this. I will, and you, if you have a difficulty in kind of remembering this, just give me like a couple of minutes. You will understand it very like in a good manner. So let's assume that you and me are the normal individuals over here, and at this point of time we are sir, is still the fifth question. Don't have so many questions, please. Okay. So you want me to kind of cover in a bit faster manner, is it? Okay, I'll try to do that. Okay, so what you need to understand is, see, what you need to understand, Xenon, is that the questions are irrelevant. The questions you will find at any particular place, right? But what is more important is the concepts behind it. So I'm just trying to revise things for you. The session will kind of continue till around 12 o'clock. I think it's okay, and I'm just trying to revise things with you. And if at all you guys want some changes in that, you just want me to kind of tell you the answers or anything like that, I'll do that. I have no issues with that. But what you need to understand is the questions and the answers are irrelevant. What is more important is the concepts behind those particular questions and all those particular stuff, right? Okay, right. Okay, now let's talk about this, what you call as the CEAP classification. So let's say if at all this is a patients who are the normal individuals, like you and me are the normal individuals, right? Okay, right. So we do not have no kind of problem at all. So no problem at all. That's fine. So we are the kind of normal individuals. Now, if at all, let's say these particular patients, they develop something which is called as a reticular vein or telangiectasia. Then over a period of time, we may develop what you call as a varicose vein, but this is asymptomatic. Okay, asymptomatic varicose vein. Then over a period of time, what can happen? The patients may develop symptoms. And what is the first symptom which usually develops in these particular patients? So they develop edema. Okay, now after this, what happens? There is something which is called as a chronic venous insufficiency. Because of this, what happens? Two things can happen. Either the RBCs can basically come out of the blood vessels, and these particular RBCs can get destroyed, and they can give rise to the hemoglobin, and this hemoglobin is basically converted to the hemosiderin. Okay, and this basically leads to your pigmentation and the eczema. Okay, and what can happen? There can be WBCs which can come over here, and they can basically ultimately lead to your lipodermatosclerosis. And what can happen is, because of this, the skin becomes kind of weak and everything. And because of this, what you need to understand is that the patients can have ulcers, and these particular ulcers can either be an active ulcer or it can be an healed ulcer. Okay, so if you remember or if you understand this particular flowchart, you will be understanding the CEAP classification in a very nice manner. So this is C0, this is C1. C1 is basically reticular vein telangiectasia. C2 is basically varicose vein, which is asymptomatic. C3 is the patients who are having the varicose vein along with the edema, pigmentation and eczema. This is basically C4A. Lipodermatosclerosis is C4B. Then out of the active ulcer and the healed ulcer, active ulcer, which is more dangerous, that is what is C6, and the healed ulcer is C5. Okay, so these are the things which you need to understand over here. Okay, right? Okay, now what you need to understand over here, that another important MCQ which they ask you is that the pigmentation is caused because of what? Hemoglobin or a hemosiderin. So please try to understand, hemosiderin is something which is responsible for the pigmentation in these particular patients. Okay, so I hope you have understood this particular point. I will not repeat it, but this particular flowchart, if at all, let's say somebody of you do not remember the CEAP classification, this particular flowchart might help you in remembering CEAP classification in a bit more kind of a simpler manner. Okay, right? Okay, right. Now let's talk about the next question. So which is the most common complication following the first significant vessel ligation during the abdominoperineal resection. So what they have given you during the vessel ligation. So what happens is that during this particular vessel ligation, the inferior mesenteric artery, which they basically ligate, during this what happens, there is a chance that the hypogastric plexus might get injured. And when this particular hypogastric plexus get injured, because of this what happens, the sympathetic kind of fibers from these particular places can get injured, and they can cause bladder dysfunction in the form of urinary retention. And what can happen in the retrograde ejaculation can happen because of the alpha-1 block, like alpha-1 fibers, which are basically kind of getting obstructed or blocked or whatever. Okay, so this is what you need to understand. This is what you need to understand. Sympathetic kind of system is getting kind of altered. Because of this, the bladder dysfunction can happen, that is urinary retention, and the patients may have a retrograde ejaculation. These are the things which you need to understand. Another important thing they can ask you is that what is, like, why do you get all these? But they have already asked you these a couple of things, okay, a couple of times. But the reason is, why are we getting this bladder dysfunction and the retrograde ejaculation? The reason for that is because of an injury to the hypogastric plexus. Okay, because of the injury to the hypogastric plexus, we are getting all these particular problems. Okay, I hope you have understood this point. Now let's move on to the next question. What all are the components of the qSOFA score? Okay, so what are the components of the qSOFA score, guys? Okay, so we have two scoring systems which you need to understand over here, SIRS and the qSOFA. I'm pretty sure that all of you have gone through this quite a lot of times. So the only thing what you need to understand is that, okay, what is an SIRS? Okay, okay, guys, I'll do that, don't worry. Okay, so what you need to understand in the SIRS, what you need to understand is that we look at the temperature, like the core body temperature. The temperature can be either less than 36 degrees or it can be more than 38 degrees. So that is one component. The another thing is the respiratory rate of more than 22, heart rate of more than 90, and WBC count, either it can be less than 4,000 or it can be more than 12,000. On the other hand, the qSOFA, what you need to understand here, the systolic blood pressure is of less than 100 millimeters of mercury, the respiratory rate of more than 20. So this is something which you need to understand over here. In the SIRS, the respiratory rate is of more than 22. In the qSOFA scoring system, it is more than what you call as more than 20. Okay, and over here, the Glasgow-Coma kind of scale is less than what you call as 14. Yeah, that's fine. Okay, so yeah, what is the thing over here? So we have the GCS, we have the systolic blood pressure, and then we have your respiratory rate. Okay, systolic blood pressure and the respiratory rate, the answer over here is B. Okay, I hope you have understood this particular point, guys. Yep, got it. So this is pretty simple. This has been asked to you so many times. Okay, so many times. But yeah, that's what you need to understand over here. qSOFA scoring system, SIRS, do not commit a mistake over here. Okay, right. Now, a patient is brought to the emergency room following the road traffic accident. On examination, the patient opens his eyes. So over here, E2. Okay, E2. It is E2. Then, okay, we got the answer. Basically, speaks inappropriately and withdraws his limbs to the painful stimulus. So speaks inappropriately. So what is verbal response? Verbal response is basically okay, so what is this particular verbal response? Verbal response is basically your, okay, so what is the verbal response? It is V3. Okay, inappropriate words is basically V3 and it is M3. Okay, so I hope you have understood this particular point. So withdraws to the limb. Okay, so follows command, localizes pains. Okay, so the options are kind of messed up over here. The options are messed up over here. It should be E2. Then what is the verbal response? It is V3 and what is M4. Okay, so the options are messed up over here. The answer is this, E2, V3 and M4. Okay, so I hope you have understood. Now quickly, I am pretty sure that all of you understand the GCS and everything, but let's kind of quickly cover it. What is an eye-opening response? Spontaneously. Okay, spontaneously, that is kind of 1. Then 2 is basically to the verbal command. Then what do we have? 3 is basically to the painful stimulus, and no response at all is 4. Okay, so no response at all is 4. Okay, so that is what you need to eye-opening response. What about the verbal response? In the verbal response, what you need to understand is, what is 1? 1 is basically well oriented. Okay, so patients are well oriented to the time, place and person. This is, oh, sorry, my bad, I just messing things up. Okay, so what you need to understand, it is 4 which is your spontaneous, 3 is basically verbal command, 2 is basically painful stimulus, 1 is basically no response. Over here also it is 5 is basically very oriented, 4 is basically confused. Okay, 3 is basically inappropriate words. 2 is basically what you call as your incomprehensible sound. 1 is basically what you call as your no response. Okay, and finally what we have a motor response. So motor response is again 6 is basically follows command. 5 is basically localizes pain. 4 is basically withdrawal to pain. Then 3 is basically abdominal flexion. Then there is an abdominal extension, that is M2, and the M1 is basically no motor response at all. Okay, so I'm pretty sure that you guys know this particular stuff, but just revise it. Committing a mistake in the GCS is again unpardonable. Now, two or three important tricky questions which they are basically asking you in this particular GCS is that if at all they give you that the patients are intubated. Okay, so if they give you that the patients are intubated or tracheostomized, okay, then what you're going to do, so do not assume, okay, do not assume that the verbal response of the patient is going to be, let's say, V5 or V1 or anything like that. Do not assume. It has to be VNT. NT basically means non-testable. Okay, non-testable. Okay, NT basically stands for non-testable. Are you understanding my point? VNT basically stands for non-testable. But what you need to understand is that, yeah, so what you need to understand over here, that if it all, okay, so let's say if it all they give you, let's say E4 is there and the patient is tracheomatized, and M kind of M, let's say 3 is there, or M4 is there, or something like that. So what is going to be the GCS of this particular patient? It is going to be VNT. Okay, so ideally it should be 4 plus 4, 8. So it should be 8 NT by 15. This should be ideally the answer. If at all they do not give you NT, then if they give you T, that is also fine, that's okay. But sometimes, very rarely, what they do is, in the options, they will not give you NT or anything like that. They will just give you 8, 9, 10, 11. Then do not mark it as 9 or anything like that. The answer is still going to be 8. See, ideally these options are wrong. But in the exam, you cannot argue, right? You have to mark something and move ahead. So if at all, ideally they should give you NT, but if they don't give you NT, don't mark it as 9 or 10 or 11 or whatever. Mark it as 8, because that is the best possible answer over here. Ideally, all the options are wrong, but the best possible answer is basically 8. Okay, so this is what you need to understand over here. Now, finally, what you need to understand is there's something which is called as a pupillary reactive score. Okay, so what is this pupillary reactive score? Okay, in you and me, what is there? Both the pupils are reacting. Okay, but if at all there is a patient in whom both pupils are non-reactive, so what is going to be the pupillary reactive score of this particular patient? 0 or 2? What is going to be? Okay, so please try to understand. If at all both the pupils are non-reactive, then the score is 2. If at all one pupil is reactive, then the score is going to be 1. Okay, and if at all both the pupils are reactive, then the score is going to be 0. Okay, please try to understand this particular point. Okay, if at all both the pupils are non-reactive, then the answer is what you call as if both the pupils are non-reactive, then the score is going to be 2. Okay, got it? Okay, now these are the important things which you need to understand in the GCS of this particular patient. Now let's move on to the next question. So we have a, let's say, 48-year-old male like man who underwent a bilateral hernia repair for the inguinal hernia. Post-operatively, he complained of a dull aching pain in the outer aspect of the right thigh. So what is this? This is a characteristic description of meralgia paresthetica, which is going to happen if at all you end up kind of putting a tacker in this lateral cutaneous nerve of the thigh. Okay, so femoral branch of the, this is a branch of the femoral nerve. Okay, so the, yeah, this is basically the lateral cutaneous nerve. Okay, understood? Right. Now there's a patient who has been brought to the emergency room after an alkali injury of the esophagus on accidental ingestion of the poison, total dysphagia. What is the next step in the management of this particular patient? Okay, so now the patient has been brought to the hospital and the patient is basically having alkali injury. Okay, now what is the next step in the management? And the patient is having a complete dysphagia, total dysphagia. So what is the next stage, next step in the management of this particular patient? So please try to understand the next step in the management of this particular patient is a feeding jejunostomy. Okay, so you have to perform a feeding jejunostomy in these particular patients. Very, very important. Okay, right. Okay, I hope you have understood this point. The answer is feeding jejunostomy. See, other options are obviously not there. Stenting of the lesion, obviously at this point of time, the esophagus will be very, very friable. So obviously you're not going to do that. A gastrojejunostomy, no. Gastrojejunostomy is not going to help at all. And esophagojejunostomy is also not going to help. Okay, now a couple of things which you need to understand over here in these particular patients are, okay, so first of all, what are your thoughts on endoscopy? Okay, what are your thoughts on endoscopy? Should it be done? Should not be done? Should it be done early, not early, late, done or not done? If it is done, should it be done early or late? Okay, so what are your thoughts on this? Can you please help me with this? Okay, so please try to understand the endoscopy in these particular patients has to be done, and it has to be done early. Early endoscopy is the management. Okay, so how this particular early endoscopy helps, this is important. Okay, whenever the patient comes to the emergency room, we have to perform an endoscopy, and we have to kind of perform a skilled endoscopy first measure. Very nice, very nice. Okay, so we have to perform an endoscopy early, and based on this particular endoscopy, what do you basically get? You get a Zarger's classification. Okay, Zarger's classification is something which you basically get in the patients with this corrosive esophageal injuries. Okay, so corrosive esophageal injuries, early endoscopy is kind of the must over here. Okay, now what can happen, that either there can be a through and through perforation. If at all there is a through and through perforation, that's the end of the story. But many times what happens, that the alkali and everything, it just causes a partial injury to the esophagus, and over a period of time the patient lands up into a total dysphagia. Okay, so I hope you have understood this particular point. Okay, now last thing which I want to ask you is that, let's say there is a patient who had a corrosive acid injury. Okay, because of this, what happened, the patient needed a esophagectomy. Esophagectomy was needed. So esophagectomy was done, but after the esophagectomy, you have to kind of put some conduit, right? So you have to put a conduit. So what is a preferred conduit? Okay, so can you please help me with this? I am pretty sure that you would have read it in the esophageal cancer. For example, let's say there is an esophageal cancer. What is going to happen? I'm going to remove my esophagus and I'm going to replace it with something, right? So that is what is called as a conduit. So in these particular patients also, because let's say if at all there is a long segment stricture, there is a complete dysphagia. Okay, so every patient with a corrosive acid injury doesn't need esophagectomy, but if at all there is a long segment stricture with a complete dysphagia, in these particular patients, you have to perform this esophagectomy. And if at all you perform this particular esophagectomy, yes, that's what I wanted. So all of you guys are saying stomach, ileum, right? No, see guys, stomach is not used. That's what I was trying to kind of emphasize over here. Stomach is not used over here, is not used in the corrosive acid injury. Why so? See, if I kind of drink the acid or something like that, where is this particular acid going to go? It is going to go from the esophagus into the stomach itself, right? It is going to go into the stomach and it is going to stay in the stomach for a prolonged period of time. So esophagus, it was coming in contact for, let's say, 15 seconds, 30 seconds, 45 seconds, but it is going to stay in the stomach for around 2 hours. So it is going to cause scarring and the contracture of the stomach. So stomach cannot be used in the corrosive acid injury. Are you understand my point? So here, the preferred conduit which we have is a colon. Please try to understand this point. Okay, so colon is the preferred conduit over here. Jejunum is usually not used because jejunum has other important roles to play in our body. But so after stomach, what is the next conduit which we use is a colon. Okay, I hope you have understood this particular point. Okay, right? Okay, right. Okay, now Sertralin was trying to tell me that, you know what, stomach and the gastroepiploic artery. Okay, so which gastroepiploic artery, right or the left? Can you please help me with this? Which gastroepiploic artery is based on? The stomach. Okay, right? It is based on the right gastroepiploic artery, right gastric and the right gastroepiploic artery. Right gastroepiploic is obviously a better answer, right? I understood. Now, don't get me wrong. In case of your what you call as esophageal cancer, like whenever you are like there is a patient with an esophageal cancer and you're subjecting that particular patient to the esophagectomy, after that esophagectomy, definitely whatever the conduit you're going to use, the preferred conduit is going to be your stomach, no doubt about it. But in these particular patients, after the corrosive acid injury, the preferred conduit which you basically use is your colon. Okay, so somebody is asking me to brief on the conduit. So please, it's very simple. After the esophageal cancer, the preferred conduit is the stomach, which is basically based on either the right gastric or the right gastroepiploic artery. If both are given in the options, it is a right gastroepiploic artery. If stomach is not there, the second best option which we have is what you call as a colon, and what we use the left sided colon, so it is basically used in the left colic artery. Jejunum can be used, that's okay, but it is usually not preferred because it has other important roles to play in our body, and duodenum can never be used as a conduit. Okay, so only these 3-4 points you have to kind of remember as far as the conduit is concerned. Okay, I hope you have understood this point. Okay, now let's move to the next question. It's one of the simplest questions ever. So patient with the diabetes mellitus, blah blah blah, feeling pain in the region below the scrotum, associated with a fever. On debridement, there is a black mass excised. It is a characteristic suspicion of what you call as a necrotizing fasciitis or your Fournier's gangrene. Okay, Fournier's gangrene. So just a couple of words about this particular Fournier's gangrene. If I ask you that, okay, it is basically what is the most common organism which is associated with this particular infection? So it is an aerobes, but along with that, aerobic organisms are also involved. So frankly, it is polymicrobial. Okay, polymicrobial, that's fine. Now what is the kind of a status of the testes over here? The testes, are they affected? Okay, are these particular testes affected? Are these particular testes affected? The answer is big no. Okay, the testes are not affected because the testes embryologically they come from the retroperitoneum, right? So they are going to bring their blood supply from that particular testicular artery, which is a branch of your aorta. So because they have a blood supply from the aorta, they are not affected over here. Okay, I hope you are able to understand. Testes are not affected in the patients with the necrotizing fasciitis or whatever Fournier's gangrene. Okay, now just one last word. There's something which is called as a Melanese gangrene. Okay, Melanese gangrene, Melanese ulcer, whatever you want to call it. So what is this Melanese gangrene? So this is when the necrotizing fasciitis involves the anterior abdomen. Okay, so this is the necrotizing fasciitis, which is necrotizing fasciitis involving the anterior abdomen. Okay, so this is a necrotizing fasciitis which is involving the anterior abdomen. Okay, great, got it. Now there is this is again a very good question. Okay, so there is a elderly hypertensive male who presented to the emergency department with the sudden onset chest pain radiating to the scapular region and the neck. What is the diagnosis in this particular patient? Can you please help me with this, guys? What is the diagnosis in this particular patient? Yep, what is the diagnosis in these particular patients, guys? Can you please help me with this? What is the diagnosis? Okay, guys, so diagnosis in this particular patient is what do you call as? Yeah, so it is aortic dissection. Okay, aortic dissection. So this is a characteristic thing. Okay, the arch of aorta dissection. So the patients are going to have a severe chest pain which is going to be radiating to the interscapular region. Okay, so aortic dissection. So let's talk a bit about the aortic dissection. Okay, so let's try to cover a few things about your aortic dissection. Okay, so what is an important risk factor? What is a risk factor for this aortic dissection? Please try to understand. It is hypertension. Okay, hypertension is an important risk factor for these particular aortic dissections. Okay, hypertension is an important risk factor. That is the first thing. Now what you need to understand is what is going to be the clinical features. So if at all, let's say there is a through and through kind of rupture of the aorta, the patients are going to die. The patients are not going to come to you in the emergency department. But if at all the patients are coming to in the emergency department, this basically means that, okay, so if at all the patients are coming to you in the emergency department, this basically means that the patients are having a partial, or there is a like partial rupture, or just the intima is kind of separated and all those particular stuff. So the clinical features are going to be that there's going to be a pain which is radiating to the interscapular region. There's going to be a discrepancy in the systolic blood pressure in both the limbs. Okay, so all these particular things are going to be the clinical features of these particular patients, right? Now what you need to understand is that what is the classification. Now let me just talk to you about the classification. So there are two classification systems which are associated with this dissecting aortic aneurysm. One is basically called as a DBMCI classification. So what is this DBMCI classification? In the DBMCI type 1, what is happening? The ascending aorta, the arch of aorta, and the descending aorta, all the things are basically getting involved. So this is what is DBMCI type 1. What is the DBMCI type 2? In the DBMCI type 2, only the arch of aorta is getting involved. So this is what is DBMCI type 2. And what is DBMCI type 3? Only the descending aorta is getting involved. So this is what is your DBMCI type 3. Do you understand my point? So we have a DBMCI type 1, DBMCI type 2, DBMCI type 3. So DBMCI type 1 is where the like ascending aorta, arch of the aorta, and the descending aorta, everything is getting involved. Only if the arch of aorta is getting involved, that is DBMCI type 2, and if only the descending aorta is getting involved, this is what is a DBMCI type 3. So this has basically 3 types. Okay. Now there is another classification system which is called as a Stanford classification. So what is this Stanford classification? Stanford classification is just consisting of A and B. So what is A? A basically means that if at all the ascending aorta involved. So which basically means that is DBMCI type 1 and 2. This is what is your Stanford A. You understand my point? So DBMCIs 1 and 2, they are going to be your Stanford A. Okay, I hope you have understood this point. Okay, what about the Stanford B? Ascending aorta is not involved. So the DBMCI type 3 is going to be a Stanford B. Are you understanding my point? I hope you have understood this particular point. Important. Okay, why this is important? Because this you need to understand for the management. So if I ask you about the management, okay, what is the investigation of choice? If at all the patient is stable, so obviously it is going to be your what you call as your CECT, contrast and CT scan, aortography, whatever, that's what is going to be there. What about the management? Management is that if at all there is a Stanford A, okay, there's a Stanford type A, it is always surgical. You have to kind of perform a surgery. There's no way around it. But if at all you're dealing with a Stanford B classification, in this thing, what you need to understand, you can perform a conservative management. You can perform a conservative management in the patients with the Stanford B type of the kind of thing. Okay, so I hope you have understood this point. In the Stanford B, you can perform a conservative management, but in the Stanford A, it is always a surgical management. So this is all about the dissecting aortic aneurysm, which you need to understand over here. Any doubts? If you have any doubts, please put it up in the comment box. Otherwise, we'll just kind of move on. Medical, if not involving the ascending aorta. Yes, absolutely right, Sridhar, right? So Stanford B, medical. So it's not like that you're never ever going to kind of go do a surgery. If at all the conservative management fails, then obviously you are going to proceed with the surgery, and conservative management is basically with the beta blockers. So you have to control the hypertension and all those particular stuff. That is what you have to do. But if it fails, then definitely you will move on to the surgery, right? I hope you're able to understand this point. Okay, now there is a patient with a what you call as a swelling in the neck. Shows the image kind of below. Okay, so image, blah, blah, blah. So this moves with the protrusion of the tongue. So it's one of the simplest questions ever. So what is the diagnosis over here, guys? What is the diagnosis over here? The diagnosis over here is Thyroglossal cyst. Okay, yes, absolutely. The answer over here is A. Okay, what is the answer? Answer is the Thyroglossal cyst. Okay, now let's I'm pretty sure that you guys know about this in a lot of details. So here what happens, there is a thyroglossal duct which is basically coming down from the tongue, and it basically goes around the hyoid bone, and then it leads to the formation of a thyroid gland, right? And if at all this thyroglossal duct, if at all it fails to disintegrate, then what we have is a thyroglossal cyst. So thyroglossal cyst is basically what you call as your the thyroglossal cyst is basically what you call as your congenital kind of cystic swelling. Okay, so just give me a minute. Anugya is asking, sir, first step in both is beta blockers. Yeah, so what you need to understand is that, see, I understand. I understand from where are you coming, because there was one question which they had asked you, beta blockers with exploration and the surgery. Yeah, that's what you need to understand. For example, let's say you come across a patient with a dissecting aortic aneurysm, and you do know that the reason for this is the hypertension, right? So obviously you're going to give the beta blockers, right? But what you need to understand is, after giving the beta blockers, what you do you observe this particular patient, whether the patient is becoming stable or not, or whether you just give the beta blockers and plan for the surgery or an emergency surgery. Are you understanding my point? So please try to understand over here that in the stand 4-day, yes, you can give the beta blockers, no doubt about it. You can give the beta blockers, but after that you have to rush the patients for the surgery, emergency surgery. But in the stand 4-B, you can give the beta blockers and you can try to monitor whether the patients are becoming stable or not. And if at all the patients are becoming stable, then you can kind of continue with the conservative management. But if at all your management fails, then you have to definitely go with the surgery. Are you understand my point? So in the stand 4-day emergency surgery, in the stand 4-B, monitor if at all the patient is not improving, then you go ahead with the surgery. Okay. Now, Keshav Kumar, I would please request you, please don't put M4 again and again. It's kind of distracting on the chat, so even the students might have it a bit of difficulty. So please, humble request, please don't put M4 again and again. Okay. Right, now let's move on to the next question. The next question which we have is that there's a patient with the swelling of a like a neck in the like blah blah blah. We talked about this. Okay, this is what is a thyroglossal cyst. Right, now if I ask you what is the most common site, okay, which is the most common site of this particular thyroglossal cyst, can you please help me with this? What is the site of this particular thyroglossal cyst? Most common site, it is subhyoid. Okay, so this is the most common site of the thyroglossal cyst. Okay, most common site is the subhyoid. Okay, I hope you have understood this particular point. Right, now what is the risk if at all you do not operate on these particular patients? What is the risk? The risk is of the infection, and there is a risk of a malignancy. So what is the malignancy which can develop in these particular patients? We can have a papillary carcinoma of thyroid. It's a long-standing thyroglossal kind of a cyst. What we have is, we have a papillary carcinoma of the thyroid. Okay, I hope you have understood this particular point. Papillary carcinoma of thyroid. Okay, right. Okay, understood. So what we have is a papillary carcinoma of thyroid over here. Okay, just give me a minute. So just give me a minute. Okay. Now let's move on. Okay, so yeah, so finally what you need to understand, what is the surgery for this particular patients? Okay, how you're going to manage these particular patients? What is the surgery? So the surgery for these particular patients is a cyst trunk operation. Okay, cyst trunk operation. And what you basically do in these particular cyst trunk operation is that you remove the cyst, along with that you remove the tract, you remove the central portion of the hyoid bone, central portion of the hyoid, and along with that you kind of remove the base of the tongue. So these are the things which you basically remove in the, or whatever, the cyst trunk operations. Okay, so these are the things which you basically remove in the cyst trunk operation. Okay, what about the thyroglossal fistula? Is it like a congenital swelling? So no, thyroglossal fistula is not a kind of congenital swelling. Like what you call as the thyroglossal fistula, this is always an acquired, because if at all there is a thyroglossal cyst, it can get ruptured and the fistula formation can take place. So thyroglossal fistula is not a congenital swelling. Please try to understand. Okay, now an alcoholic patient with a loose motion. Now, this is a very, very witty question, so please tell me about this. So, alcoholic patient with a loose motions for a few days presented with the pain in the right hypochondrium and the fever. Ultrasound shows that there is a liver abscess of 75 cc in the volume. What is the next step in the management of this particular patient? Yeah, I want you guys to answer. So, can you please help me? What is the answer over here, guys? What is the answer over here? Can you help me with this? What is the answer? Yep, guys, what is the answer over here? Please tell me. Okay, so guys, the answer over here is a medical management. Yes, absolutely right, guys. Okay, so what is this? This is a medical management. Okay, so those of you okay, so please try to understand it's a medical management. Why? Because this particular question is prompting you that we are dealing with an amoebic liver abscess. Okay, why amoebic liver abscess? Alcoholic patient, more commonly associated with an amoebic liver abscess, loose motions. Amoebiasis basically leads to diarrhea. Are you understand my point? So all these particular things are very, very important. So yes, you are dealing with the patients with the amoebic liver abscess, and that is why the thing is going to be what you call as your medical management. Okay, right now this is an important topic, so I'll just kind of quickly cover this particular stuff with you. Just give me a minute. Just give me a minute, guys. Okay, so what you need to understand over here is that, okay, so let's talk about this. Okay, so let's say if at all there is a, let's talk about amoebic liver abscess. Amoebic liver abscess. So if I ask you what is the most common organism which is only the only organism which is associated with this is your entamoeba. Entamoeba histolytica. Histolytica. If I ask you what is an infective stage for this? Infective stage for these particular stuff, it is a quadrinucleate cyst. Quadrinucleate cyst. Now what happens is when the patient basically eats this particular quadrinucleate cyst, there is a what we call as a fecal-oral contamination. Okay, so if at all there is a fecal-oral contamination, what is going to happen? The patients are going to kind of have this particular quadrinucleate cyst, and these particular quadrinucleate cyst, what is going to happen? They are basically going to open in the intestine. Now my question is, which part of the intestine? Okay, they're going to open in which part of the intestine? So please try to understand, they're going to open in the cecum and the ascending colon. Okay, so please try to understand, they open in the cecum and the ascending colon. Okay, so I'll just move on to the next page. So they basically open in the cecum and the ascending colon. So from in the cecum and the ascending colon, what they're going to do, they're going to form an ulcer. What type of an ulcer? So they are basically going to cause a flask shaped ulcer. Now what is going to happen? These particular trophozoites are going to enter into the bloodstream, and from these particular blood streams, what are going to happen? They are going to reach to the liver. In the liver, they are going to cause enzymatic degeneration, and they are going to lead to the formation of your amoebic liver abscess. Okay, so they're going to lead to the formation of your amoebic liver abscess. Now this amoebic liver abscess just basically consists of your dead, shriveled RBCs and hepatocytes. Whatever I have kind of told you at this point of time, there are too many MCQs from here. Okay, so first they ask you which part of the intestine they're going to open up. So they are basically going to open up in the cecum and the ascending colon. They are very, very important. In the cecum and the ascending colon, what they're going to lead to? They're going to lead to a flask-shaped ulcer formation. And in the liver, they are going to lead to an abscess, which is also referred to as your anchovy sauce. Okay, so they are going to lead to an anchovy sauce pus. Okay, so all these particular things are important. Okay, now if I ask you that what is an investigation of choice for amoebic liver abscess, can you please help me with this? What is an investigation of choice for amoebic liver abscess? Please put your answers in the comment box, guys. Now, I'm pretty sure that some of you might be saying that CT scan, some of you might be saying that aspiration and culture and everything. The answer over here is in serology. Please try to understand, serology is the investigation of choice for these particular patients. Very, 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 very important. Okay, I hope you have understood this point. Serology, do not mess this up. Okay, it is not your CT scan or other thing. It is basically kind of a serology. Okay, got it? Okay, right. So Anugya, yes, definitely. So pair is basically for your hydrated cyst. That is not for this. Okay, so ultrasound is not. Okay, now if at all they ask you what is the radiological investigation of choice, radiological investigation of choice, and yes, that is what is going to be your what you call a CT scan. Okay, so that is what is going to be a CT scan. Okay, now we have already talked about this. What is going to be the management for this? The management is going to be medical, which is basically your metronidazole. Okay, so metronidazole 750 milligrams, you basically give it for around 8 to 14 days, 10 to 14 days, you basically give that. Now all you need to understand over here is that what is an indication of drainage. When are you going to drain it? Okay, so please try to understand, if at all the size of this particular abscess is more than 5 centimeters, or it is involving the left lobe of liver. Okay, if at all the size is basically more than 5 centimeters, or it is involving the left lobe of liver, then you have to kind of drain it, because there is a risk of rupture. And then there are other things like if at all not responding, I'll not write everything, I'll just kind of tell you. So if at all the patients are not responding to the conservative management, or if at all you suspect that there is you're not sure whether you're dealing with a amoebic liver abscess or what you call the pyogenic liver abscess. And then what you need to understand, if at all there is a superadded infection. So all these particular things are there, but this is important: size more than 5 centimeters and the left lobe of liver. And even in the pregnancy, because metronidazole is like not preferred to be given in the pregnancy. Okay, so there's a debate whether it is acceptable or not acceptable, but you usually do not kind of give that. Okay, now the last thing which I want to cover over here is that in the questions, if at all they give you that the patients are alcoholic, okay, then it is basically prompting towards your amoebic liver abscess. Okay, so because alcohol increases the risk of amoebic liver abscess to happen. Okay, that is one thing. Another important thing which you need to understand, now you need to tell me this. Okay, now if at all, let's say I draw this particular liver and these are the two livers. Okay, now if I tell you that there is a solitary abscess, and over here I tell you that there are multiple abscesses. So amoebic liver abscess tends to be solitary or multiple. Can you please help me with this? So please try to understand. Amoebic liver abscess tends to be solitary, but pyogenic liver abscess tends to be your multiple. Okay, there tends to be a multiple. Amoebic liver abscess is solitary. This is important, guys. Okay, please do remember this. Okay, it tends to be multiple and this tends to be solitary. Now I will not cover the pyogenic liver abscess in the entire totality. I'll just ask you, what is the most common cause of pyogenic liver abscess? And because I'm not asking you the organism, I'm asking you the route of the spread. I'll give you the options. One is basically hematogenous. That is, let's say there was a diverticulitis, or let's say there was what you call as a appendicitis or something like that. And then that particular infection basically came into the liver. That is one kind of a route of spread. Another route of spread is that there was an infection which was outside, and from an external atmosphere due to the injury, the infection has kind of gone into the liver. The third is basically that there is ascending infection from the biliary tree. Okay, yes, absolutely right. So Aisha has already told us this is yes, very good, very good. So the most common cause is basically ascending infection from biliary tree. Very good. Okay, so this is important. Do not mark it as a hematogenous. Hematogenous was, let's say, 40-50 years back, when we did not have antibiotics and everything. But now when we have in the area of the antibiotics, what you basically have is this. Okay, I hope you have understood this particular point, guys. Okay, great. Now let's move on to the next question. Okay, so yeah, this is one of the simplest questions ever. Now here there was for a 22-year blah 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 injury to the chest. 1 year later, the image has been shown to you. What is the probable diagnosis of this particular patient? So what is this? This is basically an hypertrophic scar. Okay, so hypertrophic scar. Now I do not need to tell you all these particular stuff, but hypertrophic scar is basically a scar which is basically limited to the boundary. Keloid is basically the scar which is basically going beyond the boundary. Okay, so these are the two things which you need to understand over here. Hypertrophic scar, it tends to get better over a period of time. Keloid doesn't tend to get better over it. It's not a keloid, guys, it is a hypertrophic scar. Okay, so please try to understand, it is not going beyond the boundary, right? So it is basically an hypertrophic scar over here. Okay, right, so depending on the image, you can kind of mark that, that's all okay. But yeah, I hope you have understood this is what is a hypertrophic scar according to me. Okay, need to understand. Okay, so obviously this wouldn't have been the image which has been shown in your exam. Depending on the image, you have to kind of mark that. Okay, so don't worry about it. Okay, right, now let's move on to the next question. There's a 11-month baby which is brought to the emergency with the pain in the abdomen and the multiple episodes of vomiting. Okay, now before I move ahead, so guys, what we are done with 1 year of the questions. Okay, so but before I move ahead, I want to share some things with you guys. Okay, so what we are reading, obviously all these particular things are important, but I hope you understand that where you are at this point of time, even we were at some point or the other. And I understand that every educator basically tries to give their own understanding about the life and understanding about the exams and everything. So I understand that everybody has their own opinions and their own biases and everything. What I'll do is I'll just share a couple of things with you which I personally feel are important for the students to kind of listen and to understand, and that is what I'll try to do over here. Okay, now you don't need to take it at the face value. You have to kind of understand it, and whatever resonates with you, you have to kind of take it. But I'll just tell you a couple of things. I'll be very kind of fast, but please listen, it might help you. Just give me like 3-4 minutes. Okay, so what you need to understand is that you all started your preparation, let's say 1 year back, 2 years back, 3 years back, whenever you kind of started, that's all fine. Now obviously you would have assumed that, you know what, your preparation should be in a straight path and you will end up getting a rank of within 100 and all those particular stuff. But we all understand this is life. So what happens is there is a lot of detour. We do all those stupid things and everything, and somehow we are basically coming to your exam day, right? So what I'm trying to tell you is that everything wouldn't have got planned as you would have kind of imagined, but yeah, somehow you are basically over here and you are basically giving the exam. Are you 100% prepared? Obviously not, but yes, you have done the preparation. Some are better prepared than the others, but yeah, all of you are prepared to one particular level, right? Now what you need to understand is that if at all you deserve, now please listen to me very kind of with a lot of understanding. So please try to understand that if at all you deserve to get a rank of, let's say, 2000, and you get a rank of 2000, you've done a great job actually, okay? But let's assume that you deserve to get a rank of, let's say, 1000, but you end up getting a rank of 1500. You are not being fair to you, okay? So let's say if there is one student who deserved to get a rank of 2000, he got a rank of 2000, that's great. But if at all there is another student who deserved to get a rank of 1000, but he or she ended up getting a rank of 1500, that is unfair for the students per se. Now this can happen because of a couple of reasons. So one of the main reasons is the silly mistakes. Now whenever we give any particular exam, whenever we come out of this particular exam, always we say, oh shit man, I did so many silly mistakes, right? So this is not going to change, okay? Even if you ask a toppers, even they commit a silly mistake. So there's no escape from that. The only thing is that the toppers basically commit lesser silly mistakes as compared to the other people. So toppers might kind of do, let's say, 4, 5, 6 silly mistakes, but the others, they do the silly mistakes to the tune of 10, 15, 20, whatever, X, Y, Z, okay? So please try to understand, in your exam, you have to kind of reduce the silly mistakes. Now there are two ways to reduce the silly mistakes. One is before the exam, time is already gone, so I'll not cover that particular part. Now I'll just focus on how you can reduce the silly mistakes on the day of the exam. Now this analogy is basically given by many people. Like many people have told it in a different format. For example, Harsha Bogle, whenever he kind of does the commentary, basically says that, right, the match is not of, let's say, whatever, the 50 overs, the 20 overs or something like that. They basically say that there are these many number of balls in this particular match, cricket match. So if at all you give your 100% to every ball, you will end up giving your 100% to the entire kind of match. Similar way, the Will Smith basically says that if at all you want to build the best wall in this world, just focus on laying each brick to the best of your capacity. And if at all you, what you call as lay each brick to the best of your capacity, ultimately you will give your 100% to the wall. So the whole thing, what we need to understand as a students from this is that in the exam, it is whatever, 300 questions, 250 questions, whatever. So we have a number of questions in the exam. And if we end up giving our 100% to each and every question, we will end up giving 100% to the entire paper. Now it might sound very silly and very logical, but what you need to understand is on the day of the exam, what happens is that let's say if at all you are not able to answer, let's say 4, 5, 6 questions on the first 4, 5, 6 questions, and then when you reach to the question number 7, now in your mind you are saying, oh my god, I'm screwed, right? I have not been able to answer the last, what you call as 4, 5 questions or something like that. It's okay. Those were just the 5 questions. Now just give your 100% to the rest 295 questions. In our mind, what we do is that we tend to be a bit kind of reckless in the easier questions, because we feel that we are saving the time so that we can go back and we can put the time on the questions which we were not able to solve and all those particular stuff. So I'm not trying to ask you to waste time over these particular questions, but at the same time give due diligent time, because the easier questions are the ones where you're going to end up committing silly mistakes. Okay, so if at all you give your 100% to every question, whenever you are on that particular question, just give 100% focus to that particular question. In this way you might end up reducing the silly mistakes in this exam. Okay, so this is just the 2 bits which I had to, and yeah, at the same time, don't be too scared about the exam. Okay, so being a bit scared of the exam is still okay, that's absolutely fine. Some amount of anxiety is kind of good, it is like productive. But if at all you're too scared of the exam, or if at all, let's say, you are too anxious about the exam, that is simply not done. See, at the max, what's going to happen? You're not going to get selected. That's fine. What's the big deal in that? It's a life. This exam is just one part of your life. You will do whatever you have to do in your life. Okay, so even if the AIIMS topper won, like first rank in the AIIMS, even he or she cannot say that, you know what, my life is sorted from now. The life is a marathon, it's not a sprint, guys. Okay, so even if you're not getting selected, it's absolutely okay, so don't worry about it. But yes, at the same time, it's an exam, so you have to kind of give your best foot ahead, because you have dedicated so much of money, time, efforts, not of just of your own, your family, everything. So you have to kind of give your best foot forward, but at the same time, don't be kind of burdened with so much of the stress and the burden, and don't kind of that anxiety and the burden let you down. Okay, so just relax, just go, just give your exam, and just try to gain what you deserve. Okay, so if you deserve to get n number of rank, you should get that particular rank. Just focus on that. Okay, so it's not like in a couple of days a miracle is not going to happen, that you know what, you read something or you listen to something that you end up getting a rank of 100. No, if you deserve to get a rank of 1500, you will get up that only. But if you deserve to get a rank of 1500, don't do these things so that you end up getting a rank of 2500. Okay, so your mindset on the day of the exam is again very, 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 very important. Okay, so that's just my 2 bits which I wanted to kind of share with you guys. All the best. Obviously we have the session ahead, don't worry about it. I just wanted to cover it in between so that it's a bit relaxing for you, and now we can move ahead with these particular questions. Okay, got it? Okay, right. Now let's talk about this particular question. So there is a 11-month-old baby kind of was brought to the emergency with the pain in the abdomen and the multiple episodes of vomiting. On examination, there was a mass palpable in the right lumbar kind of region. Barium enema is kind of given. What is the most likely diagnosis in this particular patient? So it's a pretty simple question. What are you basically seeing over here? This is what is your claw sign, and what is this? This is basically your Intussusception. Okay, so Intussusception, claw sign. Okay, so this is what you need to understand over here. Okay, now there are various number of signs which you basically get in these particular, what you call as an Intussusception. Okay, so all of you understand that what is an Intussusception? Intussusception is basically that there is a telescoping of the bowel into the other. So like one part of the bowel basically goes into the other, telescoping of the bowel. That is what is an Intussusception. Because of this, what happens that the patients end up having what you call as a intestinal obstruction. So what the patients end up having is an intestinal obstruction. Okay, so that's fine. Because of this, the patients are going to have the bilious vomiting and all those particular stuff, right? So yeah, there's going to be the palpable mass in the right iliac fossa. There's going to be the emptiness of the right iliac fossa, which is called as a sign of Dan's. Absolutely right. There's going to be the red current jelly stool. All those particular things are fine. What about the ultrasound? In the ultrasound, what you're going to find, you are going to have a pseudo kidney sign, and you can also have your target sign or a donut sign, or whatever you want to call it. Now it's pretty simple. Now if at all, let's say there is a telescoping of the bowel into the other, and if at all you keep your let's say you have this particular ultrasound probe. Okay, so you have this particular ultrasound probe, and if you keep it vertically, like on the transverse plane, now that is what is going to give you a pseudo kidney sign. But if you give it like a perpendicular to this particular length of this particular bowel, then you're going to get a target sign. Okay, so I hope you have understood this particular point. So yeah, pseudo kidney sign, target sign, donut sign, all those are the similar things. They are going to be found on the ultrasound. On the barium enema, what you're going to find in the barium enema, you're going to find this particular claw sign. You can also find a coiled spring appearance. Okay, so what else you can find? You can find a coiled spring appearance. Okay, so coiled spring appearance. This is what you basically find in the barium. Okay, barium enema. Okay, now what about the management? So what you need to understand, if at all there is no signs, okay, and in the simple plain x-ray, what you're going to find? You're going to find an air crescent sign. Okay, or air crescent sign on the simple plain x-ray. Now how do you manage it? If at all there is no signs of peritonitis, there are no signs of perforation, in that particular scenario, you can use an air enema. Air enema or like enema can be used, that's fine. And gastrographin enema. Okay, gastrographin enema. This is also kind of beneficial in these particular patients. So gastrographin enema or the air enema, that is what you can do if at all there is no signs of perforation or peritonitis. But if at all there are the signs of perforation and the peritonitis, then in that particular scenario, surgery and like the surgical repair of that particular intussusception part, that is something which is kind of done. Okay, I hope you have understood this point. Now this is important. A delayed intravenous urogram in the patient is shown below. What is the most likely diagnosis in this particular patient? Can you please help me with this? What is the most likely diagnosis in these particular patients? Putty kidney, staghorn calculus, PUJ obstruction, or the renal cyst. Okay, so answer over here is a PUJ obstruction. So what you can understand over here, that this is the chelicus of the kidney, and this is what is the pelvis of the kidney, and the contrast is not going beyond this particular point. So this is what is your PUJ obstruction. Okay, so this is what is your characteristic PUJ obstruction. I hope you are able to understand this particular point. Putty kidney, I hope that you have seen the image of this. This was recently asked in your INI exam as well. So putti kidney is basically a calcified kidney which you basically find in the tuberculosis. I'm pretty sure you would have known about this. Don't misunderstand this as a stag-on calculus. Okay, so this is an intravenous urogram. They have given you that there is a delayed intravenous urogram over here. Stag-on calculus will be detected on the plain X-ray. So if at all the similar kind of an image would have been given with kind of a plain X-ray, then it would have been there. Why not A? Because it is entirely different, Divya. So please try to understand over here. Putti kidney is basically seen in the tuberculosis. That's fine. And over here in this, what you're going to find the calcification. That's fine. But this is going to be found on the plain X-ray KUB. Here they have given you intravenous urogram. In other words, they are trying to tell you that what are you seeing is a contrast. Are you understanding my point? And they're giving you delayed phlegm. Okay, so delayed, it means that they waited for 6 hours, 12 hours, 24 hours, but still the contrast was not able to kind of come from the renal pelvis into the ureter. Are you understanding my point? Got it? It is not a putti kidney, guys. Please try to understand. It is not the plain X-ray. It is a intravenous urography, IVP. Okay, am I making some sense to you guys? Yeah, it is a hydronephrosis. Okay, right, absolutely right. Okay, so this is what is a POG obstruction. Renal cyst doesn't look like this. Okay, everybody have understood this particular point? Any doubts in this, guys? Any doubts in this? So stag-on calculus is going to appear in the similar format, but that is what is going to appear in the plain X-ray. Putti kidney, multiple calcifications will be seen in the kidney, but that is again going to be in the plain X-ray. Over here, what you have is the intravenous urography, and over here the contrast is basically not coming beyond that particular renal pelvis, and yeah, that is why it is a POG obstruction. You're absolutely right. In the tuberculosis of the kidney, what we are going to find is a sterile pyuria. Okay, sterile pyuria. Understood? Got it. Now, there is a 6-year-old child presented with a recurrent urinary tract infection. The micturating cystourethrogram image has been shown to you. What is this? Okay, so MCU. Now they are saying that it is an MCU which have been shown to you. So what is the diagnosis over here, guys? Can you please help me with this? Okay, so this is a vesicoureteric reflex. This is a grade 5 vesicoureteric reflex which you're basically seeing over here. Okay, so what is this vesicoureteric reflex? That is the urine is basically going from the bladder into the ureter. That's fine. This is what is called as a VUR. This happens when the intramural part of the ureter is basically shortening. That's fine. Let's not get into all those particular stuff. There's the grades of the VUR. So grade 1 to grade 5. This is what is a grade 5 VUR which you're basically having over here. Now in the MCU, another important image which you need to understand is urinary bladder diverticulum. So over here, what you need to understand that they're going to have the urinary bladder and there's going to be the outpouching from the urinary bladder. So not over here exactly at any other place, but if at all there is an outpouching from the urinary bladder, this is what they are trying to tell you about the urinary bladder diverticulum. This is something which they can also show to you. Okay, I hope you have understood this particular point. Okay, so this is about this particular image. Now let's move to the next question. A 30-year-old patient presented to the casualty after the motor vehicle accident, blah blah blah, bruise over the chest, pulse rate is 120 beats per minute, BP is 90 by 60 millimeters of mercury, respiratory rate is 40 per minute, X-ray is performed. What is the most appropriate step in the management of this particular patient? Okay, so first of all, tell me what is the diagnosis. Second of all, tell me whether the options given in the this particular kind of a question are right or wrong or whatever. So first of all, please tell me the diagnosis. I hope you're trying to tell me that this is, at least you're trying to tell me, or at least you're trying to appreciate that you're dealing with a pneumothorax. Now, most likely the patient is having a tension pneumothorax because the patient is starting to become hemodynamically unstable. Okay, so yeah, so amongst the giving options, yes, definitely the answer over here is a chest tube insertion with the drainage. Okay, so let me just quickly cover your hemothorax and let me just quickly cover your pneumothorax, and let's say we'll try to cover the hemothorax as well. So, okay, so first let's talk about the pneumothorax. Okay, so what is pneumothorax? Pneumothorax is simple. It is basically presence of the air inside the thoracic cavity. That is what you call as a pneumothorax. Okay, now here what is going to happen? The patients are going to come to you with a respiratory distress. Along with that, what is going to happen when you examine this particular patient? What is going to happen? The trachea is going to be deviated towards the opposite side. So trachea is deviated to the opposite side. If you auscultate these particular patients, what are going to happen? There's going to be an absence of the breath sound. And what else? On percussion, what you're going to find? You are going to find a resonant note. on the percussion. So if at all they have given you all these particular stuff on respiratory distress, on examination trachea elevated to the opposite side, on auscultation there is an absence of the breath sounds, and on percussion there is a resonant note. So they are basically trying to tell you that you are dealing with pneumothorax. Okay, but along with that, if at all they give you that the patient is having hemodynamic instability, and there is raised JVP, jugular venous pressure. Now they're basically trying to along with this. Okay, so this is what is your tension pneumothorax. Now I hope you understand what is the difference between the simple pneumothorax and the tension pneumothorax. What you need to understand is that in the simple pneumothorax, what is there? There's a two-way communication. So what is going to happen? The air can enter into the thoracic cavity and it can leave the thoracic cavity as well. But in the tension pneumothorax, there's a formation of a flap valve. So because of this, what is going to happen? With every breath the patient takes, what is going to happen? That is, the air is going to enter into the thoracic cavity, but the air will not be able to leave the thoracic cavity. Are you understanding my point? So yeah, that is what is the difference between the pneumothorax, the simple pneumothorax, and the tension pneumothorax. Everybody is okay on the same page? In the simple pneumothorax, there is a two-way communication. In what you call as the tension pneumothorax, what is going to happen? That the air is going to enter into the thoracic cavity, but it is not going to leave the thoracic cavity. Okay. Now there are a couple of doubts which the students are asking. First of all, the doubt is why this is a pneumothorax. So are you able to appreciate this particular part? Are you able to appreciate how black this particular part is? So this is what you need to understand, that in the pneumothorax, what is going to happen? Okay, so what you need to understand is that this particular part of the chest, does it appear more black as compared to this one? Yes, obviously, right? Why this appearing more black? Because there is only air which is present over here. Here, what is there? There is air plus bronchovascular markings. Okay, so why? Because there is lungs also over here, and that is why there is air with the bronchovascular marking. So whichever the part where there is more black, this is what is a pneumothorax. Okay, what is this? This is what is a collapsed lung, and this is what is a pneumothorax. Okay, so I hope you have understood, Prithvi. So this is how you somebody had asked me about the X-ray, so I hope you have understood. Why immediate thoracotomy? Why not immediate thoracotomy, guys? Why will you perform an immediate thoracotomy? You're dealing with a pneumothorax, so obviously that is not the answer. A is not the answer. Okay, I hope you are able to understand this point. Okay, right. So it is not the vascular markings, it is the bronchovascular markings. The bronchus is also kind of collapsed because the entire lung is collapsed. That is what is absent. Okay, I hope you are able to understand this point. Okay, now one thing which I wanted to cover with you. Okay, and how do you need to understand how do you distinguish the pneumothorax from the tension pneumothorax? Hemodynamic instability, raised JVP. Some people talk about the tracheal deviation. The tracheal deviation is going to happen in both, but the tracheal deviation will be more in the patients with the tension pneumothorax as compared to that of a simple pneumothorax. I hope you have understood this particular point. Now let's talk about the management. If at all there is a patient with a tension pneumothorax, how are you going to manage these particular patients? So the management of the tension pneumothorax, ideally there is something which is called as an emergency management, and there is a definitive management. So what about the emergency management? Emergency management is wide bore needle insertion. Okay, so there is a wide bore needle insertion. Wide bore needle insertion, what you can understand is that in the children it is going to happen in the what you call as a second intercostal space in mid clavicular line, and in the adults it is going to be in the fifth intercostal space in the mid axillary line. Are you understand my point? So the wide bore needle insertion in the children, it is going to be in the second intercostal space in the mid clavicular line. In the adults, it is going to be in the fifth intercostal space in the mid axillary line. Okay. Now, what about the definitive management? What about the definitive management? So definitive management is going to be ICD insertion. So this is how you're going to manage the patients with a tension pneumothorax. Okay. I hope you have understood this particular point. Okay. Understood? Now, let's move to the next question. Any doubts in the pneumothorax, guys? If you have any doubts in the pneumothorax, please do ask. Otherwise, we'll just move on to the next question. Okay. Okay. Anjali, we just talked about this. Okay. Right. We just talked about how do you kind of look for the Oh, here, hemothorax. Okay. So how do you look for the hemothorax on the X-ray? Okay, so please try to understand in the hemothorax what is going to happen. Anybody wants to help her? So what you need to understand in the hemothorax, what is going to happen? There's going to be the, I'm drawing here with the black, but in the X-ray, what you're going to find that there is white out of the lung. Okay, there's going to be the white out lung. So what you just do me a favor, at this point you are on your kind of X-ray, like on your phone, right? Just Google what you call as a hemothorax X-ray, and now you'll be able to understand what I'm trying to tell you. Okay, over there is going to be the white out of the lung, but you cannot tell with certainty that you are dealing with a hemothorax only, because a pleural effusion will also have a similar kind of an X-ray. So that is why whenever you are having a patient of a hemothorax, the definitive way to kind of understand that is you have to put in a needle and you have to aspirate. On aspiration, if at all you get a blood, then you say with confirmation that you are dealing with a hemothorax. Okay, and you also need to understand how do you distinguish pneumothorax from the hemothorax. So all the other things will be the same. Respiratory distress is going to be there. Trachea will be deviated towards the opposite side. When you auscultate the lungs, the breath sounds will be absent. But over here on the percussion, you are going to have a dull note. So on the percussion, if you have a dull note, that is what is your hemothorax. Okay, on the X-ray, what you're going to have a white out of the lung, you put in a needle, you try to aspirate. If at all the blood comes out, that is what is a hemothorax. What is the management of the patients of the hemothorax? The management is ICD insertion. Now, if at all we have reached to this particular point, can you please tell me what is an indications of a thoracotomy in the patients with the hemothorax? So if at all there is a patient with a hemothorax, what is an indication of thoracotomy? What is an indication of the thoracotomy? Can you please help me with this? What is an indication of a thoracotomy? The indication of thoracotomy is if at all there is more than 1.5 liter of the blood which is coming out, like the stat output. Okay, so first we are talking about the stat output. Okay, if at all the stat output is more than 1.5 liter after a blunt trauma, or the stat output is more than 1 liter of the blood which is basically coming in the what you call as a penetrating trauma. Okay, so more than whatever 1.5 liters in case of a blunt trauma, or more than 1 liter in case of a penetrating trauma, or yes, absolutely right, if at all there is more than 200 ml per hour for consecutive 3 hours, then you have to perform a thoracotomy. And last question, which type of a thoracotomy? Posterolateral thoracotomy or an anterolateral thoracotomy? So please try to understand over here what you basically perform is a anterolateral thoracotomy. What you perform is a anterolateral thoracotomy. Over here, what you basically perform is an anterolateral thoracotomy. Okay, I hope you have understood this particular point. Very, very important. Okay, now a 54-year-old kind of patient complains of a recurrent kind of swelling on one side of the neck. She is afraid of eating food. As it worsens to swelling, imaging has been shown to you. What is the likely diagnosis? Now this is a good question. So can you please help me? What is the diagnosis over here, guys? Yeah, what is the diagnosis over here? What is the diagnosis over here? Okay, so please try to understand the diagnosis over here is your like salivary gland stones. Okay, so what is this? Salivary gland stones. Okay, so yes, sialolithiasis. That is what is the diagnosis over here. Okay, now what you need to understand is, let's talk about the sialolithiasis a bit. Okay, so let's talk about sialolithiasis. Sialolithiasis. Okay, so here what is there? There's a stone in salivary gland. If I ask you which is the most common salivary gland in which the stones can form, okay, in which the stones form, can you please help me with this? What is the most common salivary gland where the stones form? It is the submandibular. Okay, so we have a submandibular salivary glands where the stone formation basically takes place. You understand my point? Submandibular salivary gland. So what happens in these particular submandibular salivary glands is that there is a submandibular salivary gland. There is a duct of the submandibular salivary gland. Now this duct is basically hooked. Okay, so what happens? The one nerve basically hooks this particular duct. Can you please tell me which nerve hooks this particular duct? Anybody guys, can you please tell me which nerve is basically hooking this particular nerve, this duct? This is what is a lingual nerve. Okay, so lingual nerve is basically hooking this particular duct. Okay, so please try to understand. So because of this, what happens, that is the saliva has anti-gravity drainage, and because of this, the stone formation can happen in these particular ducts. Okay, so that is why that is a cyalolithiasis. This is what is the pathogenesis of the cyalolithiasis. Now, can anybody explain to me why she's afraid of eating food as it worsens the swelling? So how will the food worsen the swelling? So over here, the characteristic history will be that there is a swelling which occurs in the postprandial period. After the food has been eaten, the saliva secretion basically increases, and now what is going to happen? The saliva will get secreted by the submandibular gland, but it is not going to kind of come out because of these particular stones, and that is why there's going to be the pain, and that is why the history they have given you, that the patient is basically afraid that of eating food because the pain and the swelling basically increases after eating food. Are you understanding my point? So this is what is the cyalolithiasis, submandibular gland, why this is happening, and anti-gravity drainage and everything. Management is obviously you have to kind of put an incision on the duct, and you have to kind of remove the stones and all this particular stuff. The important thing which you need to understand is what is the most common structure injured during the surgery. Can you please help me? What is the most common structure which is going to get injured during the surgery? It is going to be the lingual nerve. Please try to understand lingual nerve, because it is so closely associated with this particular submandibular gland duct. That is why this is the most common structure which can get injured during this particular surgery. Now, another important thing which you need to understand over here, that okay, so once they had also asked you the question on the like if at all the lingual nerve gets damaged, what is going to be the effect of that? Okay, so the sensations from the anterior 2/3 of the tongue will be lost. From the floor of the mouth, the kind of the sensations will be lost. The secretions from the submandibular gland, they will be kind of reduced, but the motor component is not there, so the tongue deviation will not happen. So that was one of the questions, so please do remember that. Now, another question which you need to understand is, what are the nerves associated, or otherwise what are the nerves which can get injured during the submandibular gland surgeries? Okay, so what are the things? We have already talked about this. One is the lingual nerve, lingual. What are the other? Hypoglossal nerve, and then we have a marginal mandibular nerve, mandibular nerve. So please try to understand, these are the three nerves which are associated with the submandibular gland. The most common which can get injured is your lingual, then you have a hypoglossal and all those particular stuff. Okay, I hope you have understood this particular point, guys. Okay, now let's move on to the next question. So there's a patient which is presenting to the emergency with the claudication of the calf muscles, numbness in the thigh and impotence, bilateral resting pain, and image of the gangrene for blah blah blah. What is the artery which is involved over here? So what you need to understand is that you need to look at all the symptoms. What is the, okay, so I'm pretty sure that all of you have reached to the diagnosis that we are dealing with a peripheral vascular disease, right? Now let's talk about the symptoms over here. So with the claudications in the calf muscles, okay, numbness in the thigh also is there, with impotence. So impotence is also there. So if at all there is an impotence, what you need to understand is that even the iliac vessels are involved. Okay, so what you need to understand is even the iliac vessels are involved. So yes, so because see, all these particular symptoms are there, but you have to see what is the proximal most kind of feature which they have given you. So they have given you impotence, which basically means that even the aorto-iliac bifurcation, iliac vessels are also involved. So there's one step above that. So aorto-iliac bifurcation is kind of involved over here. Are you understand my point? So they can also ask you what kind of a, like if at all you want to perform a bypass surgery, which vessel are you going to prefer? Aorto-iliac bypass is going to be kind of done. Okay, so I hope you have understood this particular point. So aorto-femoral bypass, because there's an involvement of the iliac vessels, aorto-femoral bypass has to be done in these particular patients. I hope you have understood this point. Okay. Right, now there are various things which I can go into this particular peripheral vascular disease. I will not go. So you need to understand about the ABPI, ankle brachial pressure index. Just for my understanding, if I ask you what is a critical limb ischemia, ABPI value of less than Please put it in the comment box. I hope that you're thinking and you're writing it as a less than 0.3. ABPI, ankle brachial pressure index, less than 0.3 is a critical limb ischemia, which is basically happening in this particular patient because there's a gangrene which has already set in. Okay, I hope you have understood this point. Just read this PVD. This is again an important kind of a stuff. Okay, if at all some other question comes up, I'll kind of cover that particular stuff again. Okay, now 7-year-old kind of what you call as a came to the gynecologist, blah blah blah, for the hysterectomy. The doctor explains the benefits and the risk of the procedure, included in the surgery, and obtained a consent. She signed the form. What type of the consent is this? Okay, so this is basically an informed consent. Okay, this is what is an informed consent. Okay, now there's something which is called as an implied consent also. So what is an implied consent? For example, if the patient is basically coming to the hospital, it is implied that the patient wants to get treated from you. So that is what is an implied consent. So in the OPDs, what you basically do, you take an oral consent. You take an oral consent. Why? Because you ask the patient, okay, I want to examine. Can I examine you? Obviously, you don't kind of keep on signing the consents in the OPDs, right? But before the surgery, what you basically need is an informed written consent, because the patients are signing on this particular consent. Okay, so just read this particular consent. These are important. Sometimes the questions are asked to you. So this is basically based from, this is from your ethics wala chapter. So in your love and belief, there is one chapter on the ethics. Don't sit and read that particular chapter in detail. I'm just trying to explain you that this is not from abstract world. This particular question has come from the ethics chapter of your love and belief. Okay, right. Now, which of the following is most likely to be seen due to the rupture of the saccular aneurysm in the brain? So what are they basically talking about? They're talking about the berry aneurysm. So if at all there is a rupture of the berry aneurysm, what is going to happen? Okay, what is going to happen? Please tell me. There's going to be a, what do you call? A subarachnoid hemorrhage, right? SAH is going to happen. Obviously, there's going to be a subarachnoid hemorrhage. Now, if I ask you, what is the most common cause of a subarachnoid hemorrhage? Can you please put it in the comment box, guys? What is the most common cause of a subarachnoid hemorrhage? Okay, so the most common cause of a subarachnoid hemorrhage is what? Anybody? Please put it in the comment box, guys. So the most common cause of a subarachnoid hemorrhage is, it's not the rupture of a berry aneurysm. It is the trauma. So please try to understand the most common cause of the subarachnoid hemorrhage is the trauma. So this rupture of the berry aneurysm, it might sound very, very fancy, right? But that is not kind of that. The most common cause of this is still the trauma. Okay, so please try to understand this point. Okay, now what about the subarachnoid hemorrhage? So all those particular things you would have heard of. Thunderclap headache. What do you understand by the thunderclap headache? That is from the onset of these particular symptoms, the pain basically increases very, very drastically. And you might also have heard that this is the worst headache of my life. Okay, so thunderclap headache, worst headache of my life, all these particular things are basically correlating with your subarachnoid hemorrhage. That is the first point. Now here the patients are going to have okay, now on the examination, you're not going to find any focal neurological deficit. What do you understand by focal neurological deficit? For example, in the EDH, what did I tell you? That there is an ipsilateral side, there is a pupillary dilatation. On the contralateral side, there is a weakness of the limbs and everything. In the subarachnoid hemorrhage, you are not going to have all these particular stuff. So in the subarachnoid hemorrhage, what you basically have is, you basically have what you call as a meningeal signs. Okay, so what you have is a meningeal signs, like there's a meningeal irritation, so there's going to be your neck rigidity, there's going to be the vomiting. Okay, so all these particular things are basically you're going to find in the patients with the subarachnoid hemorrhage, neck rigidity, vomiting, all those particular things. Okay, I hope you have understood this particular point, right? Okay, okay, now what you need to understand over here, that on the lumbar puncture, okay, in the lumbar puncture, what you're going to find in the lumbar puncture? In the lumbar puncture, you are basically going to find xanthochromia. Okay, xanthochromia. Xanthochromia is something which you're going to find in you can have in the lumbar puncture. Okay, so the when you do a lumbar puncture, you can basically have this particular orangish colored cerebrospinal fluid which is basically coming out. That is what is a xanthochromia. Okay, management is conservative, no surgery can be done over here. So that is what you need to understand over here. Okay, right? I hope you have understood this point. Now let's move to the next question. Identify the condition given in the figure. underlying cause of this particular condition. Okay, so what is this? This is what is your carcinoma breast. What you are basically having over here is a subdermal lymphatics infiltration. So what is this? This is what is called as a Pau d'Orange. Okay, Pau d'Orange. Okay, so what I'll do is I'll quickly revise with you the TNM staging of your breast, which is a very, very important stuff. So let's kind of talk about that. Okay, so let's talk about the TNM staging of the breast carcinoma. Okay, so what do you have? T1, T2, T3. What is T1, T2, T3? It is less than 2 centimeters, 2 to 5 centimeters, more than 5 centimeters. Okay, but this is basically limited to the breast only. Okay, so no other kind of things are involved. So this is T1, T2, T3, less than 2 centimeters, 2 to 5 centimeters, and more than 5 centimeters. Okay, what about T4? T4 is further divided into A, B, C, and D. So guys, whatever, let's say if at all you screw up in your life, whom do you blame first? Do you blame yourself first, or do you blame the external environment and the factors first? Always you should try to do a self introspection. Okay, so you have to kind of blame yourself first. So what you need to understand is that there is an involvement of the chest wall. Chest wall involvement is T4A. Okay, and what about the T4B? There is a skin involvement. There is a skin involvement. What you need to understand, the chest wall involvement, what is included? Okay, so what is included in the chest wall involvement? So the ribs and intercostal muscles, or let's say the serratus anterior. So all these particular things are included. What is not included is pectoralis major and pectoralis minor. This is not included. Okay, so this is not included. Please try to understand this. Okay, so if at all in the question they give you that there is involvement of a pectoralis major and the pectoralis minor, this is not a chest wall involvement. Please try to understand this point. What is the chest wall involvement? So we have a ribs, intercostal muscles, and the serratus anterior. Involvement of these things is basically considered as a chest wall involvement. I hope you are able to understand this point. What about the skin involvement? If at all they give you that there is a nodule, okay, or if at all they give you that there is a Pau d'Orange, or if at all they give you there is an ulceration. So all these particular things are the skin involvement. But what is not a skin involvement? So if at all they give you that there is a dimpling, okay, or there is a retraction of nipple. Okay, so if at all they give you that there is a dimpling or there is a retraction of the nipple, that is not a part of your called as a skin involvement, not a part of your skin involvement. I hope you are able to understand this particular point. Okay, what is T4C? This is basically A and B. So like T4A and B, like skin plus the chest wall involvement together, this is what is a T4C. And what is T4D? This is inflammatory breast carcinoma. Okay, so this is what is your inflammatory breast carcinoma. I hope you have understood this particular point, guys. Yeah, I hope you have understood this particular point. These are very, very important. So T1 is basically less than 2 centimeters, 2 to 5 centimeters, more than 5 centimeters. T4A is basically involvement of the chest wall. T4B is basically involvement of the skin. In the chest wall, ribs, intercostal muscles, and the serratus anterior, that is what is kind of like that is what is a part of your T4A, but the pectoralis major and the minor, that is not included as a T4A. What about the skin, like T4B? There's a skin involvement, that is a nodules, Pau d'Orange, and the ulcerations, that is what is a part of your skin involvement. But your dimpling and the nipple retraction are not a part of your skin involvement. Why do the dimpling and the nipple retraction occurs? That occurs because of the involvement of the ligament of Cooper, which is not a part of your skin involvement. What is a T4C? There is a T4A plus B. What is a T4D? This is an inflammatory breast carcinoma. Okay, I hope you have understood the T staging of the TN, like the breast cancer. Now let's talk about the N staging. So in the N staging, what you have N1, then you have N2A and N2B, and then we have N3, which is A, B, and C. Okay, so what is N1? N1 is mobile axillary lymph nodes. Okay, mobile axillary lymph nodes is N1. N2A is basically fixed axillary lymph nodes. What is like N2B? This is internal mammary lymph node with no axillary lymph node. What is N3A? N3A is infraclavicular. N3B is axillary plus internal mammary group of lymph nodes. N3C is your supraclavicular group of lymph nodes. You understand my point? So please try to understand. N1 is mobile axillary, N2 is basically A is basically fixed axillary group of lymph nodes, N2B is internal mammary kind of group of lymph nodes without the what you call as the axillary group of lymph nodes. N3A, B and C is infraclavicular axillary plus the internal mammary group of lymph nodes, N3C is supraclavicular. Okay, now which of these particular lymph nodes cannot be assessed on the clinical examination? This is basically your internal mammary. You can do the percussion and everything, but they're not very specific, so you usually have to use a what you call as a CT scan in order to evaluate the internal mammary group of lymph nodes. Okay, so I hope you have understood about the T and N staging of your breast cancer. Okay, now let's move to the next question. All of the following are the components of the M2B except, okay, so which is not a part of your M2B: parathyroid adenoma, megacolon, and what you call as a marfanoid habitus, or mucosal neuromas. Okay, so which is not a part of your this particular MN2B. Okay, so okay, frankly this particular question is a bit kind of absurd. Okay, megacolon is very rarely occurred, but yeah, we can surely say that, you know what, it is a parathyroid adenoma. Now I don't know what were the options. Mucosal fibromas and the like neurofibromas and all those particular stuff are very commonly present. B, it's like sometimes very rarely present, that's fine, but we do understand that parathyroid adenoma is definitely not present. So in such scenarios you obviously mark the answer as A. Okay, so I hope you have understood this point. Now quickly let me just kind of cover the MEN syndromes with you. So what we have is MEN1, MEN2, MEN1, MEN2A and MEN2B. Okay, so what is MEN1? MEN1 is basically this is 3 P's. What are the 3 P's? This is parathyroid. Then what we have? We have pituitary, and then what we have is a pancreas. Okay, so in the parathyroid you can have an adenoma or the carcinoma, and in the pituitary you have a macro and microadenomas, and in the pancreas what you have is a neuroendocrine tumor. And which is the most common neuroendocrine tumor associated with the pancreas? It is a gastrinoma. So in MEN1 syndrome, the most common pancreatic neuroendocrine tumors is your gastrinoma. Overall, it is insulinoma. So overall, what is the most common pancreatic neuroendocrine tumor? It is what is an insulinoma, but in patients with the MEN1 syndrome, it is gastrinoma. What is MEN2A? Here, this is basically the syndrome of 2 P's. Okay, so P, P, P and P. So this P is basically your parathyroid, and along with this you have a pheochromocytoma, and obviously medullary carcinothyroid is kind of given, that is basically present in MEN2A and MEN2B both, and here there is only one P, which is your pheochromocytoma, but here parathyroid is not present. Along with this, obviously medullary carcinothyroid will be present, and along with this mucosal neuromas and the marfanoid features. Okay, marfanoid features and the mucosal kind of neuromas, all those particular things are going to be present in the MEN2B. I hope you are able to understand this particular point. Medullary carcinothyroid is basically common in like MEN2A and MEN2B. So if at all they give you that there is a medullary carcinothyroid and there's a pheochromocytoma, what is this, MEN1, MEN2A or MEN2B? You cannot tell, because they have to give you. If at all they give you marfanoid features and this mucosal neuromas and everything, then yes, the answer is MEN2B. But if at all they just give you that there is a pheochromocytoma and the medullary carcinothyroid without this marfanoid features and everything, then it is a MEN2A. Okay, so these are the very basic questions which you need to understand and you need to remember over here. Okay, got it? Now let's move on to the next question. Now this is something which you should remember. Okay, now I'll give you the explanation for this also. So which is the most common site of the intraperitoneal abscess over here? So yeah, I would like to hear your answers. Okay, so what is the answer over here? I'll just enlarge it. So these are, this is 1, this is 2, this is like, this is 1, this is 2, this is 3, this is 4. Okay, so what is this? Which is the most common site of your intraperitoneal abscess collection? Okay, intraperitoneal abscess collection. Okay, so please try to understand the answer over here is D, that is subhepatic. Okay, subhepatic. Please try to understand this particular point, guys. Okay, so this is again, okay, so intraperitoneal abscess. I will not I'll share this particular PDF with you. You can just go through it. So it can happen in the left superior and like left subphrenic. So this one was left subphrenic, then this was lesser sac. 2 is basically lesser sac, 3 is basically the right subphrenic below the diaphragm, and 4 is basically subhepatic. So out of these 4, subhepatic is the most common site of the intraperitoneal abscess formation. So you can just go through this. I have written like all the screenshots I have kind of given over here. So this is what is your lesser sac. This is also, it's okay. So right, this is your right subphrenic, but this is what is your intraperitoneal, that is a right subhepatic. Okay, so the space is kind of bounded above by the liver, below blah blah, transverse colon blah blah. It is the deepest space of the 4 and the commonest site of the subphrenic abscess, which usually arises from the appendicitis blah blah blah. So what you need to understand is that intraperitoneal abscess collection basically happens depending on whatever the locations are there. Okay, so whatever the locations are there. Okay, for example, if at all there is some injury to this kind of pancreas, then there will be left subphrenic kind of collection. Or if at all there is some injury to the spleen, there's going to be the left subphrenic collection. If at all there is a gastric perforation, there will be abscess in the lesser sac. Okay, but overall, so just go through these particular. I will not be kind of reading these particular things for you, but I will ask the Bhatia people to kind of share the PDF with you, and you can just go through these particular screenshots. Okay, that's fine. Okay, got it. But yeah, out of these 4, the subhepatic is the most common site. Please remember that. Okay, right. Now let's move on to this particular question. 35-year kind of old patient presented with the severe abdominal pain and the vomiting. His vitals are stable. Radiograph is shown below. What is the most effective way to treat this particular patient? So what is this? What are they basically trying to show you in this particular X-ray? I hope they're trying to show that you are dealing with the patients with a what you call as perforation. Okay, so this is what is a perforation, visceral perforation, and over here obviously you have to kind of go ahead with the resuscitation with the laparotomy. Okay, so yeah, as simple as that. So this is basically a resuscitation with the laparotomy. Okay, now if I ask you that what is a Rigler's sign, can you please tell me what is a Rigler's sign? Rigler's sign. So I'm sorry, I do not have the X-ray of this, but again I would ask you guys to kind of just Google it up. So what is a Rigler's sign? Rigler's sign is again an X-ray finding. This is again an X-ray, plain X-ray finding in the patients with your perforation. So what happens over here is that there is air which is basically present inside the intestine and also the outside the intestine. So the wall of the intestine is very well kind of delineated. Okay, so it is very well delineated. This is what is called as a Rigler's sign. Please do not confuse it with Rigler's triad. Yes, that's what I was trying to ask you, Rohit. This is not a pneumobilia. Pneumobilia, gallstone ileus, that is a different stuff. That is what is called as the Rigler's triad. Ganesh and Rohit, please remember, pneumobilia, gallstone ileus, that is a different thing. There what you basically get is a Rigler's triad. That is also one of the questions. We'll talk about that. But here what I'm trying to talk to you about is a Rigler's sign. This is a plain X-ray finding which you basically get in the patients with the perforation. Eagle eyes, that is not the same. Please remember. Okay, this is not the same. I hope you're able to understand this particular point, guys. Okay, so what we are dealing with over here is a Rigler's sign, which is basically a plain X-ray finding. Unfortunately, I do not have the X-ray in front of me. Please try to kind of Google it once. Okay, class till when? Okay, so it's 10, right? I think I'll be able to wrap it up by 12. I think so. Okay, I'll wrap it up by 12. Whatever the questions are completed, I'll kind of do that. We will do it by 12. Okay, so Divya. Okay, got it? Right. Now, a 30-year-old male presented with a recurrent painful perianal nodule on the buttocks with the serous discharge. What is the most probable diagnosis of this particular patient? What do you think? What is the diagnosis over here? Diagnosis over here is a fistula in ano. Okay, so what is this? This is what is a fistula in ano. So perianal nodule is there with the serous discharge is there, and I hope you are able to appreciate there is an opening also. So this is what is your fistula in ano. Okay, so what is this? What is this? This is basically your fistula in ano. Okay, I hope you have understood this particular point. Okay, got it. Now, okay, okay, so I'll just talk to you about important things about the fistula. Okay, so I'll just talk to you about the important things about the fistula. Okay, so if I ask you what is an what happened to my pen, man? Okay, so guys, what we'll do is we'll just take a small break. Okay, we'll just take a small break. Actually, my pencil has also kind of got discharged, and I also want to drink water a bit. Okay, so what we'll do is we'll just take a small break of 10 to 15 minutes. So now it is 9:50. Okay, so now it's 10. We will start the class again at 10:15. Will that be okay? Will that be okay, guys? Yep. So we'll start the class at 10:50. Okay, right? We'll restart the class at 10:15. You also have a small break, but please do come. I'll wrap things by 12 o'clock. Okay, so just give me like some time. We'll restart this particular stuff in let's say 15 minutes. Okay, got it. Okay. Okay, guys. Yeah. So hi guys, welcome back. Let's start again. Okay. So what we were trying to discuss when we left was okay. So we were trying to talk about this fistula in ano, right? So let's cover a few important points about the fistula in ano. Okay. So let's cover the few important points about the fistula in ano. If I ask you, what is? Oh, what's the issue, man? Just give me a minute. I think there's some technical issue. Just give me a minute. Just give me a minute. 1 minute. Okay, hopefully the glitch has kind of resolved due to a lot of problem, man. Okay. Sorry. Yeah, the glitch has resolved. I'm really sorry. This has gotten a bit loose. I'm really sorry for all these particular stuff. Okay. Now, if I ask you, what is an investigation of choice? Okay, what is an investigation of choice for what you call as your fistula in ano? Fistula in ano. What is a investigation of choice? Can you please help me with this? So the investigation of choice over here is an MRI. Now you would have heard of these Goodsall's rule and this acetic acid and digital examination and all those particular stuff. Yes, all those particular things are there. But hands down, the investigation of choice is an MRI. This basically helps us tell you a lot of things. It basically tells us whether we are dealing with a simple or a complex fistula. It basically tells us whether it is a low-lying fistula or a high-lying fistula. It basically tells us about all those particular stuff. Okay, it basically tells us where is the internal opening, whether there is one internal opening or multiple internal openings. It tells us about the tract. So MR fistulogram hands down is the investigation of choice for your whatever the fistula in ano. Now what you need to understand is that about the management. Okay, so I will not cover the entire thing about it, but if at all, let's say if at all they give you an healthy person. Healthy person basically means that the patient is young, patient is not having any comorbidity, nothing is there. And if at all they ask you how you're going to manage these particular patients, so never mark it as a fistulectomy. No, you cannot excise the fistula out. You cannot do that. What you basically do is you perform a fistulotomy. Okay, so what you end up performing is a fistulotomy. What do you understand by this fistulotomy? You open the fistula tract. Okay, you kind of marsupialize this particular kind of fistula tract. So the treatment of choice is your fistulotomy. But please do remember, if at all they give you that there is a patient who is having an HIV, or if at all they give you that there is immunocompromised patient. Okay, so if at all they give you that there is a patient who is having an HIV, or let's say there is an immunocompromised patient or something like that, in these particular patients what you need to understand is that the fistulotomy is not an option, because if you do a fistulotomy, what is going to happen, there's going to be the large defect which is going to be there, which is not going to heal in a good manner. Or if at all they give you that there is a very high fistula, okay, high fistula, it means that it is basically above your external internal sphincter. It's a complex fistula, okay, something like that. In that particular scenario, if you perform a fistulotomy, then the patients will become incontinent. So in these particular patients, what you need to understand, the management is this CEAP. Now the ceton can be, what is the ceton? Ceton is basically a thread which you basically pass from the anal canal and internal opening, external opening and everything. So there is something which is called as a drainage cetum. There's something which is called as a cutting ceton. So drainage ceton is basically used for the infection. If at all they give you that there is a pus which is coming out from the fistulous tract, then you basically put a drainage ceton. But if at all they kind of say that the pus is not coming, mucus is coming and you want to treat it, then you basically perform a what you call as a cutting ceton. So in the cutting ceton, what you do, you tighten this particular string every week. Okay, so over a period of time, the entire tract is basically fibrosed. Okay, so this basically gives that time to heal, like the above part gets healed and the lower part basically gets cut with the cutting ceton. Now you understand my point? So this is what you need to understand about the management. I have just covered it in a very, very brisk format. Healthy person, fistulotomy, that is fistulectomy is not never an answer. Fistulotomy is the answer, and ceton is basically used if at all you are giving the HIV patient, immunocompromised patients, infected fistula or the high fistulas, okay, or the complex fistulas or something like that. Okay, I hope you have understood this point. Now let's move on to the next question. Yes, all of you would have answered this. It is a bladder extrophy. Okay, so what is this? This is a bladder extrophy. So here what happens, that is the anterior wall of the abdomen and the anterior wall of the urinary bladder that fails to form. So what happens is the posterior wall of the urinary bladder is exposed to the external atmosphere. Okay, so the posterior wall of the urinary bladder is basically exposed to the external atmosphere. So this is what is called as an extrophy of a urinary bladder. Very, very, very important. Gastrocalcis, I will show you. There is one image which is coming up. That's fine. So here what happens is that like the posterior wall is basically shown, right? So sometimes even the ureteric orifices are available, and then like the urine basically comes out directly from this particular wall or something. Now the only thing which you need to understand over here is what is the risk. Okay, so what is the risk if at all there is a patient with the extrophy of bladder? What is the risk? The risk is of not the squamous cell carcinoma. No, Yuvraj. There is a risk of adenocarcinoma. So any congenital anomaly of the urinary bladder, for example, let's say there is a urachus or there is an extrophy of bladder, these guys have a risk of your adenocarcinoma of the bladder. Okay, adenocarcinoma of the bladder. Now another important thing is this associated with hypospadias or epispadias? Okay, this is associated with what? Hypospadias or the epispadias? So please try to understand. This is one which is associated with an epispadias. Okay, so extrophy of bladder, epispadias complex. Okay, please try to understand. This is the one which is basically associated with an epispadias. Okay, I hope you have understood this particular point, guys. Okay, now the route of metastasis of the prostatic carcinoma to the lumbar vertebra is thoraco, whatever this transcoelomic spread, lymphatics, prostatic venous plexus, inferior vesicle. So this is what is a prostatic venous plexus. Okay, so Battison's plexus, from here what happens, that the tumors, they basically spread to the spinal cord. Okay, so the most common, one of the common sites is basically the spinal cord. The compression fractures, they occur in the patients with the prostate cancer. Okay, so let's not dive deep into the prostate cancer. It's a very, very big topic altogether. But yeah, try to understand the metastasis basically happens with this, what you call as a prostatic venous plexus. Okay, got it? Now, the following surgery of the varicose vein, the patient developed the numbness along the medial aspect of the leg. Which nerve is commonly affected over here? So please try to understand. It is the saphenous nerve, right? Okay, so what is the answer over here? It is the saphenous nerve which is basically getting affected over here. Okay, so what you need to understand over here, that okay, so let's talk about the great saphenous vein. Okay, so we have here what you call as the medial malleolus. Does it like this great saphenous vein, is it present anterior or it is present behind this particular medial malleolus? Can you please help me with this? Okay, so this great saphenous vein, this is present anterior or posterior to the medial malleolus? Important MCQ, guys, please tell me this. Okay, so great saphenous vein is basically arising from anterior to the medial malleolus. Okay, so try to understand that this is basically arising anterior to the medial malleolus. But when we perform the Trendelenburg's operation, or if you know what is this Trendelenburg's operation, so this is what is called as a stripping of the great saphenous vein. Okay, so this is what is called as a stripping of the great saphenous vein. So the stripping of the great saphenous vein, this is basically done only till the knee joint. Okay, this is basically done only till the knee joint. Are you understand my point? So the stripping of the vein is only done till the knee joint. You don't go below this, because if you go below this, there is an increased risk of injury to the saphenous nerve, and that is why you kind of do it only till the knee joint. Are you understand my point? So these are the two important things which you need to understand over here. Yes, the answer over here is a saphenous nerve. Okay, so that's fine. Now, a 73-year-old male patient with a bedridden for the 15 years. What is the grade of this particular bed sore? So just look at this. What is the grade of this particular bed sore? Okay, so what is happening over here? What is this? Is it grade 1, 2, 3, or 4? Okay, now again, this is not a perfect image for this, but I hope you are able to understand. It is somewhere around grade 4, because you understand that the entire epidermis is definitely involved, and the underlying soft tissue is also involved over here. When you debride it, you will kind of get to know that. That's fine. Okay, but the more important thing is, what is grade 1? What is a grade 1 bed sore? Anybody can you please help me with this? What is a grade 1 bed sore? Okay, Acha, I'll ask you a question. Okay, if at all there is a patient, okay, if at all there is a patient who is having a superficial loss of epidermis, but the dermis is not involved. What is the grade of this particular bed sore? Okay, so if at all there is a patient who is having a superficial loss of the epidermis, but the dermis is not involved, what is this? What is the grade of this particular bed sore? What is the grade? What is the grade? Anybody guys? Yes, right. Okay, so what is the grade of this particular bed sore? So please try to answer. Okay, this is a grade 1, right? No, this is a grade 2. So all of you guys have answered it absolutely correctly. Ajay, Swastik, and everybody. So what you need to understand, grade 1 is basically a non-blanchable erythema. Okay, so all these particular things. Grade 2 is basically superficial loss of the epidermis, not involvement of a dermis. In the type 3, like the grade 3, epidermis and the dermis is involved. In the grade 4, epidermis, dermis, and the like underlying tissue, the muscles and the bones are also involved. Are you understand my point? So the important thing to remember is this grade 1. Grade 1 is not. So in the exam, if at all they give you this like superficial loss of epidermis, your mind will say that, you know what can happen less than this. Okay, no, but the grade 1 is basically non-blanchable erythema. So I hope you have understood this. Okay, so Ankit, Anjali, everybody who have kind of like committed a mistake over here, please do remember this. Superficial loss of epidermis is basically grade 2, and non-blanchable erythema is basically grade 1. Okay, I hope you have understood this particular point. Okay, understood? Got it? Now, what else you need to understand over here? Okay, so bed sores, they occur, I hope that everybody knows that they basically occur in a bedridden patients. Okay, in the bedridden patients. Okay, so if at all there is a bedridden patient, blah blah blah, what is going to happen over a period of time? There's going to be increase in the pressure, and this particular pressure, if at all it rises above what particular level? If at all it basically goes more than 30 millimeters of mercury, this is what is referred to as your capillary closing pressure. Okay, so if at all this particular pressure goes beyond this particular capillary closing pressure, then what is going to happen? The microvasculatures are going to get cut off, and the skin and the subcutaneous tissue will not get adequate amount of blood flow, and then what is going to happen? That necrosis and everything is going to land up over there. Are you understand my point? So this is what you need to understand about the pathogenesis of the bed sore. Now another important MCQ which I want to ask you, which is the most common site of the bed sore. Okay, so just look at this particular image and tell me what is the most common site of the bed sore. Okay, so can you please help me with this? What is the most common site of the bed sore? Come on, fast. Please tell me what is the most common site of the bed sore. Okay, so the most common site for the bed sore formation is here, not the sacrum. Okay, it is ischium. Okay, ischium, followed by the greater trochanter, and last may you have the sacrum. So third is the sacrum, then you have other things as well. The least common site is your occiput. Yes, I hope like everybody is answering it correctly. Good. So it is ischium is the most common site, but they've given this particular ischium at like many times. So now they might not give ischium, they might give a greater trochanter. So don't mark it as a sacrum. Sacrum is usually the most common wrong answer which we get, but I hope you've understood that. Good that all of you have answered it correctly. So what you need to understand is that ischium is the most common site. If they don't give ischium, then there is a greater trochanter, then you have the sacrum. Okay, I hope you have understood this particular point. Okay, now Lastly, you have to kind of go with the debridement. And okay, so there is a dressing which you basically use as a vac dressing. So what you need to understand is, in order to use this particular vac dressing, what you need to understand is that there should be no slough or infection in the wound. Okay, so there's going to be no slough or the infection in the wound. So once you've debrided, you do the dressing, and after this particular slough and the infection is kind of gone, now you can put these particular patients on the vac dressing. What is the pressure which you basically keep in this particular vac dressing? So please try to understand, minus 125 millimeters of mercury. This is the pressure which you basically keep in this particular vacuum assisted closure dressings. Okay, and lastly, what you need to understand is about the prevention. This has been given in your 11 as well. So please try to understand, the prevention is that if at all, let's say you're dealing with a bedridden patient. So in the bedridden patient, what you need to understand, the patient has to get up, like the position of the patient has to be changed. So what you need to understand, the position needs to be changed every 2 hours. Okay, so the position needs to be changed every 2 hours. And if at all, let's say there is a patient who is on the wheelchair. Okay, if at all there is a patient who is in the wheelchair, the patient has to kind of lift himself up every 10 minutes for 10 seconds. So every 10 minutes, the patient has to kind of lift himself or herself up for every kind of 10 minutes every 2 hours. Okay, so I hope you have understood this particular point, guys. Okay, yes, air mattress, change of the position, everything, but these particular things you also have to remember, that position change every 2 hours, and if at all that the patient is on the wheelchair, then the patient has to lift themselves up every 10 minutes for 10 seconds. Okay, there's a patient who presented with the pain and the swelling near the angle of the mandible. The swelling is non-tender. Okay, so forget about this. Pain is usually not there, and there's a firm for 3 months. What is the diagnosis over here? So this is what you need to understand over here. Characteristic description. So this is what is your pleomorphic adenoma of the parotid gland. Okay, so this is a pleomorphic adenoma of the parotid gland. Okay, so I hope you have understood this particular point. So location over here, pleomorphic adenoma of the parotid gland. Okay. Now, so this is again like a benign condition, which is basically consisting of like multiple like epithelial component, mesenchymal component, and all those particular stuff. The important thing is the treatment. Okay, so let's talk about this. Okay, so whenever you are going to manage these particular patients, okay, so whenever you are going to manage these particular patients, what you need to understand is, will you perform an enucleation? Enucleation is not done. Okay, it's not done. Why enucleation is not done? Because there is a risk of recurrence. Okay, so if at all you kind of do an enucleation, there's going to be recurrence, because these particular patients have pseudopodia. Okay, now most of the time what is going to happen, only the superficial lobes are involved. Okay, so you perform a superficial parotidectomy. You understand my point? So most of the times only the superficial lobe of the parotid is involved, and that is why you perform a superficial parotidectomy. You understand my point? And if at all, let's say there's an involvement of a deep lobe. Okay, if at all the deep lobe is involved, then what you perform is a deep or let's say total parotidectomy. So how would you come to know with the clinical scenario that whether there is only the superficial lobe which is involved or the deep lobe has also been involved? So if at all they want you to kind of say that, you know what, this is a patient who is having a kind of a deep lobe of the parotid is also involved over here. So then what you need to understand is that what are they going to give you? They are going to give you that, you know what, that there's a patient who is having the like the tonsils are basically moved like medially, or the uvula has been moved medially. Are you understanding my point? So on basically what you call on the oral examination, the tonsils are moved medially. This basically tells you that the deep lobe has also been involved, and now you have to perform a total parotidectomy. Somebody is asking, why not parotid abscess? Parotid abscess will not appear like this. Okay, there will be overlying skin changes, there will be a fluctuant swelling. Here there is a bossylated firm kind of a swelling which they had kind of given you. So swelling is non-tender and firm. In like you will not have a firm swelling in you, what you call as your in the parotid abscess. Now, Sheetal, you are saying facial nerve involvement. No. So, total parotidomy is not done if at all there is a facial nerve involvement. Okay. So, can facial nerve get involved? Yes, it can get involved very, very rarely. In 5% of the patients, the pleomorphic adenoma may turn malignant, and then there can be involvement of the facial nerve. And if at all there is an involvement of the facial nerves, then you have to perform a radical parotidectomy. So, in the total parotidectomy also, what you basically do is you preserve the facial nerves, but in the radical parotidectomy you have to kind of excise the facial nerves also, and if at all there is a facial nerve involvement, then that is again an indication of to give you the radiotherapy. You understand my point? So this is basically benign, but in 3 to 5% of the patients the malignant transformation can take place. Okay, so I hope you have understood this, Sheetal. If facial nerve is involved, then it is a radical parotidectomy, it is not a total parotidectomy. Okay, I hope you have understood. Now, there's a middle-aged female patient with a history of a radiation exposure which is presented with a painless kind of slow-growing midline anterior neck swelling. After 6 months, there is a bilateral cervical lymphadenopathy which is developed, surgery is done, and the image has been kind of shown to you. What is the not true? Which of the following is not true for these particular patients? Okay, so FNAC is not diagnostic. Okay, nuclear features are characteristic of this particular tumor. Okay, now spread is through the lymphatics. It has excellent prognosis. What is the answer over here? Can you please help me? Yes, absolutely right. The answer is A. FNAC is definitely diagnostic in these particular patients. Okay, so what is the diagnosis over here? We are basically dealing with the papillary carcinoma of thyroid. Okay, so let's kind of talk about the thyroid malignancies. Okay, so papillary carcinoma of the thyroid. Okay, so let's talk about this first. Okay, so what you need to understand is this papillary carcinoma of thyroid. What is this? This is what is the most common thyroid malignancy. This is the one which is having the best prognosis. This is more common in the females as compared to that of the males. That's fine. Now, if I ask you what is the risk factor, so as it is given in this particular kind of question, that is the radiation exposure in the childhood. Okay, so radiation exposure in the childhood, that is one of the very, very important risk factors for the development of a papillary carcinoma of thyroid. Along with that, long standing thyroglossal cyst. Okay, so long standing thyroglossal cyst and the radiation exposure to the childhood, that is a very, very important risk factors for the development of a papillary carcinoma of thyroid. Now, if I ask you, what is the presentation of these particular patients? How are they going to get, how are they going to present? So there are two kinds of presentations which can happen. So one is basically called as a lateral aberrant thyroid nodule. Okay, or there can be occult thyroid malignancy with lymph node metastasis. You understand my point? So what do you understand by the lateral aberrant thyroid nodule? It means that there is a thyroid nodule which is not in the midline, it is basically present laterally. And what is this occult? What do you understand by occult? Occult basically means hidden. Okay, this basically means hidden. So this basically means that in the thyroid there is no swelling, but you have a lymph nodes metastasis. Why? Because in these particular patients there is an early lymphatic spread. Okay, so what do you find in these particular patients? There's an early lymphatic spread in these particular patients, and that is what you need to understand over here. What is an investigation of choice for the kind of papillary carcinoma of thyroid? So FNAC is the investigation of choice. What you're going to find over here? So you are going to find samoma bodies. You're going to find what you call as a orphan nuclei, and there can be pseudo grooving. Okay, pseudo grooving. All these are the FNAC findings which are basically diagnostic of the patients with the papillary carcinoma of thyroid. Okay, so I hope you have understood this particular point. And what about the treatment? It is basically total thyroidectomy with modified radical lymph node dissection if at all the lymph nodes are kind of enlarged over here. Lastly, if I ask you what is the genetic mutation which is associated with this, so this is BRAF gene mutation. So I'm just covering it very, very in the fast manner, but I hope you have understood. These are all the important points. Okay, so BRAF genetic mutation which is associated with these particular patients. Okay, so more common in the females as compared to the males, around 30 to 40 years of age. Most common, best prognosis, public carcinothyroid, radiation exposure, long-standing thyroglossal cyst. These are the two important risk factors. Presentation, lateral apparent thyroid nodules or occult thyroid malignancy with a lymph node metastasis. Early lymphatic spread is a feature of this. Investigation of choice is FNAC. What you basically find is your soma bodies, orphan hernia nucleus, such as pseudogrooving. So what you're basically seeing over here, these are your somoma bodies. Okay, so these are your somoma bodies. Okay, understood. Now let's kind of quickly cover about the important things about the other kind of thyroid malignancies as well. So what about the follicular? If at all we talk about the follicular, first of all, here there is a lymphatic spread or a hematogenous spread. So please try to understand here, hematogenous spread is more common as compared to that of the lymphatic spread. Okay, so lymphatic spread, hematogenous spread, which is basically to your bones, and in the bones, what kind of metastasis do they occur? Osteolytic. Okay, so please try to understand osteolytic metastasis, pulsatile bony metastasis or osteolytic metastasis, which is basically more common in the follicular carcinoma of the thyroid. Okay, now over here, what you need to understand, what is the genetic mutation associated with this? This is a PTEN gene mutation. There are others as well. There are a number of genetic mutations, but PTEN gene mutation is something which is common with the follicular carcinoma of thyroid. Okay, right. Now, what is the risk factor for the follicular carcinoma of thyroid? The risk factor is long-standing. If at all they say that there is a long-standing keloid goiter, this is a risk factor for your follicular carcinoma of thyroid. Okay, now if I ask you that there is a patient who is coming to you with a thyroid nodule, a very, very important MCQ, guys. Okay, you did an FNAC in these particular patients. So you did an FNAC, and what did you find on the FNAC? You find that there is an amyloid stroma. Okay, so you find that there is an amyloid stroma. So what is the diagnosis of this particular patient? Can you please help me? What is the diagnosis? So the diagnosis of this particular patient is medullary carcinoma of thyroid. Okay, what is this? This is a medullary carcinoma of thyroid. Please remember this, guys. Okay, very, very important point. Amyloid stroma on the FNAC is your medullary carcinoma of thyroid. Okay, I hope you have understood this particular point, guys. Okay, now let us talk about the next question. I'm just trying to see how many questions are remaining. Okay, got it. Right, so let's talk about this particular question. Now, according to me, the options are wrong over here, but yeah, please try to forget about the options, just write your answer in the comment box. Okay, so here what you need to understand, there is a patient who came to the emergency after the stab injury to the abdomen. The vitals were kind of stable. Image of the injury is kind of shown below. What is the next step in the management of this particular patient? Okay, so here what you're able to appreciate, that there's a stab wound on the anterior abdomen. Okay, so here there is a stab wound in the anterior abdomen. I deliberately did not tweak with the options because these were the options which I got from the kind of the Dr. Bhatia Institute. But what you need to understand, what is the diagnosis? The answer is not given in these particular options, guys. Okay, right? So answer is not given in these particular options. Okay, so further investigation, IV fluids, wait and watch and dressing, exploratory laparotomy. No, the answer is local wound exploration. Okay, what is the answer over here? It is a local wound exploration. Okay, so this is a very, 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 very important. No, it's not a CEAP, it is a local wound exploration. No, this is all wrong. Okay, so this is all a further investigation. Okay, not even a further investigation, it is what you have to kind of do. You understand my point? So options are basically wrong here. What you need to understand, you have to perform a local wound exploration. So what I'm going to draw right now, it is very, very important for you. It will take around 5 to 7, 8, 10 minutes, but it is very, very important. It is a modified protocol from your Schwartz. So please kind of walk you through it. It's very, very important. You should understand because many questions come from the management protocol of a penetrating abdominal trauma. So please stay with me and just try to understand this. Okay. So let's say if at all there is a patient who is having a penetrating trauma to the abdomen. Okay. So there is a patient who is having a penetrating trauma to the abdomen. If at all the patient is hemodynamically unstable. Okay, so if at all there is a patient who is hemodynamically unstable, then what you're going to do? You don't need any other investigation. If at all there is a patient with a penetrating abdominal trauma and the patient is hemodynamically unstable, you don't need any other investigation. You straight away take the patients for a exploratory laparotomy. You understand my point? You do not need any other investigation. You straight away take the patients for an exploratory laparotomy. Am I making some sense to you guys? Directly take the patients for an exploratory laparotomy. But let's say if at all there is a patients with a penetrating trauma, what you need to understand is that okay, and let's say if at all the patients are hemodynamically stable, okay, stable hemodynamically. I hope you understand what is a hemodynamically stable, right? Systolic blood pressure more than 90 millimeters of mercury. So if at all the patients are hemodynamically stable, then there are two things. Either the patients might be having a gunshot wound or the patients might be having a stab wound. So patients might be suffering from GSW. What do you understand by the GSW? Gunshot wound. And the patients might be having a stab wound, right? Okay, so the patients might be having a gunshot wound or the patients might be having a stab wound. If at all there is a patient who is having a gunshot wound, okay, if at all there is a patient who is having a gunshot wound, it can happen either to the anterior abdomen or it can happen to the back or the flank. Okay, so if at all there is a gunshot wound to the anterior abdomen, you do not need any other investigation. You straight away take the patients for an exploratory laparotomy. But if at all, let's say there is a gunshot wound to the back or the flanks, now you perform a CECT, and then if at all it is positive, then you take the patients for an exploratory laparotomy. Are you understand my point? So if at all there is a gunshot wound to the anterior abdomen, nothing else needed, straight away take the patients for an exploratory laparotomy. Now coming to the stab wound. Now the stab wound, again, it can happen, let's say to the what you call as a back or the flank. In this particular scenario, you repeat the same thing. Okay, so you perform a you again perform a CCT, and if at all it is positive, then you take the patients for an exploratory laparotomy. Or you can have a stab wound to the anterior abdomen. So this is what the scenario they had asked you in your question. Okay, so we will talk about this. Or what you can have what you call as a stab wound to the, okay, there's a stab wound and there is an evisceration or there is a bile staining of clothes. You understand my point? So there is an evisceration, basically means that the intestine is basically coming out, or there is a bile staining of the clothes. Okay, if at all these particular things are happening, then what you need to understand in this particular scenario also, you don't need any other investigation. Okay, so please try to understand. Over here also you need no other investigation and you straight away have to perform a exploratory laparotomy. Okay, so am I making some sense to you guys? I hope you're able to understand this particular point. So please try to understand. Okay, so I will just cover this anterior abdomen also, and then we will revise this particular protocol again. Okay, so let me just kind of cover this anterior abdomen as well. Okay, now let's say if at all there are two people. Okay, so there are two friends who both have basically gone to the market to kind of get something. So let's say there are two friends who have okay, draw them very small. Okay, let's say there are two friends who have gone to the market to kind of get something, and what you need to understand, one of them is quite obese. Okay, one of them is quite obese and the other one is really not that obese. Okay, so please try to understand over here. So this is basically the fat. Okay, so this is what is the fat, and what is this internal part is your peritoneum, and this is what is the skin. Okay, now what happened was that a kind of thief came, and the thief basically kind of did what you call as put a stab injury to these particular patients, right? So what the thief did, the thief came with a knife and he basically did a stab injury to both of these particular patients. Okay, now both these particular patients have been brought to you in the emergency room. Are you understand my point? So let's look at this. Okay, so here there is a patient who has come to you with a stab injury. The patient has been brought to the emergency room. Now, why are we concerned about? Okay, what are we concerned about? We are concerned about that whatever that particular knife is there, it could have caused an injury to the intestine or some liver or spleen or something like that. But in order to that, for that particular knife to cause injury to the spleen and whatever other things, it should have penetrated through this peritoneum, right? If at all it did not go through this particular peritoneum, can it cause injury to the liver, spleen, intestine, anything? No, right? It cannot. So when the patients are brought to the emergency room, what you want to know? Okay, what you want to know? You want to know whether the peritoneum has been breached or not? This is what you basically want to know. And how do you kind of know that? By performing something which is called as a local wound exploration. Okay, so by local wound exploration, what you want to know, why are you performing these? Whatever you do in this life, you have to have some aim, right? So why you're performing this local wound exploration? Because we want to know whether the peritoneum has been breached or not. So in this particular scenario, as the peritoneum has been breached, the local wound exploration is going to be positive. And if at all this particular is positive, then I'll tell you what to do. But if at all the local wound exploration is negative, which is going to be happening in this particular patient because the peritoneum has not been breached. So over here, you're sure that there is no intra-abdominal injury in this particular patient. What you can do, you can take the stitches and you can discharge the patient. Okay, you understand my point? You can take the stitches and you can discharge the patient because you're very sure that there is no intra-abdominal injury in these particular patients. But over here, if at all the peritoneum has been breached, now there is a suspicion that yes, maybe intra-abdominal injury would have occurred, but you're not kind of sure about it. So now what you basically do, you admit the patient and you monitor the patient, and if at all the patient deteriorates, then in that particular scenario you do the surgery. Are you understand my point? So this is how you manage the anterior abdominal stab wound. So if at all there is a stab wound to the anterior abdomen, what you basically perform it is a local wound exploration. What is this LWE? LWE stands for local wound exploration. So local wound exploration, if at all it is positive, then what you do, you admit the patient, you monitor. If you want, you can get a CT scan. If at all the patient deteriorates, then you basically perform an exploratory laparotomy. Am I making some sense to you guys? I hope I'm making some sense to you guys. What I'll do, I'll quickly revise this particular protocol with you because it is very, very important. Just stay with me for a couple of minutes more. So penetrating abdominal trauma. Whenever you have a patient with a penetrating abdominal trauma, first thing which you have to see is the hemodynamic stability. If at all the patient is hemodynamically unstable, no other investigation needed, straight away exploratory laparotomy. But if at all there is a patient who is hemodynamically stable, now what you need to understand, you need to see whether you're dealing with a gunshot wound or a stab wound. If at all you're dealing with a gunshot wound, you need to understand that the gunshot wound is basically in the anterior abdomen or to the back of the flank. If at all it is to the anterior abdomen, now again, no other investigation needed, straight away go and do an exploratory laparotomy. But if at all there is a gunshot wound to the back or the flank, in that particular scenario, you perform a CCT. If at all that is positive, then you do an exploratory laparotomy. If at all there is a stab wound to the anterior, like if at all there is a stab wound, it can happen to the back and the flanks. If at all it is happening to the back and the flanks, you perform a CCT. If at all that is positive, then you go ahead and do an exploratory laparotomy. If at all there is a stab wound to the and it is causing evisceration. So let's say if at all the intestine is coming out, or let's say the bile staining of the clothes or something like that, or peritoneum is coming out, in these particular scenarios, you have to perform an exploratory laparotomy because there is definitely a suspicion of an intra-abdominal injury. Okay. Now in the anterior abdominal stab wounds, like the question which was shown to you, what you have to perform is a local wound exploration. What is the aim of performing this local wound exploration? You want to see whether the peritoneum has been breached or not. And if at all it is positive, it means that the peritoneum has been breached. Now what you do? You admit the patient, you monitor the patients, and if at all the patient deteriorates, then you perform an exploratory laparotomy. I hope you have understood. This is a very, very important protocol, and in number of like at least 6, 7, 8 questions I have seen in the past like 5, 6, 10 years, which have been asked from this particular protocol, and this is directly from your Schwartz, guys. So this is completely reliable. I hope you have understood this particular point, guys. Okay, got it? Now let's move on to the next question, guys. Okay, so the green color in the triage, obviously this is one of the simplest questions ever. So green basically kind of tells you about the ambulatory. What is a moderate, or so high priority is basically red, moderate priority is basically yellow, then dead is or moribund is basically your black, and this ambulatory is your green. Okay, so let's not waste any time on this triage. I'm pretty sure all of you would have like understood this, like all of you know that. Okay, so no point in kind of discussing anything over that. That's fine. Okay, so this is again what you need to understand, but just by the image you can basically tell that what is this. This is what is your Fournier's gangrene. We have already talked a couple of things about the Fournier's gangrene. It's a very, very simple stuff, but I don't know why they keep on asking you the questions over this. So what you need to understand over here, this is what is a Fournier's gangrene. What you do is a debridement. All you need to understand is the testes basically is preserved because the blood supply of the testes is basically from the aorta. Okay, directly from the aorta, the testes are getting the blood supply. Okay, I hope you have understood this particular point, right? Now, laboratory kind of investigation of the patients being evacuated for the jaundice shows an elevated bilirubin and the alkaline phosphatase levels of the remaining liver enzymes are kind of normal. What is the diagnosis? So here what they're trying to tell you is that there is an elevated bilirubin and there is an elevated alkaline phosphatase level. ALP is kind of elevated, bilirubin is elevated. What are you dealing with? Obviously you're dealing with an obstructive jaundice. So very basic question, nothing major about this. So this is what you're dealing with, an obstructive jaundice. So yeah, very simple. I can cover a lot about the obstructive jaundice also, but yeah, there's a lack of time. I will just kind of move on and I'll move on to the next question. Okay, so we're done with the two papers. Now let's talk about this asepsis score. So what you need to understand is that asepsis score and the Southampton scoring system, this is what you really need to kind of understand, and you can kind of you need to remember them. So over here it is basically the induration. Okay, so just go through these guys. You need to remember this Southampton scoring system and the asepsis scoring system. You have to kind of sit with them and you have to kind of learn them. These are important. Over here definitely the answer over here is an induration. So I hope you have understood this particular point, guys. Okay, got it. Now let's move to the next question. There is a middle-aged man complains of an upper abdominal pain with like heavy meals. There's a tenderness in the upper abdomen. On the x-ray, widening of the mediastinum, pneumomediastinum is here. What is the diagnosis? Okay, so can you please tell me what is the diagnosis over here? Okay, so what is the diagnosis over here, guys? Can you please tell me with this? Okay, so this is what is a spontaneous perforation of the esophagus, guys. Okay, what is this? This is a spontaneous perforation of the esophagus. Now, please try to understand. If I just simply ask you that can the perforation of the esophagus lead to peritonitis? Okay, can the esophageal perforation lead to peritonitis? Yes or no? The answer is yes, it can, because what you need to understand is there is an intra-abdominal part of the esophagus also. It is not a buoy reef. They have not given anything like a buoy reef. They have not given you vomiting. They have not given you vomiting against the closed glottis. So, but like, I hope you have understood the drill. So what you need to understand, the patients may have the upper abdominal pain is there, right? So, and I wouldn't have been out. So there's a tenderness also, even if they give you that there is what you call as a peritonitis or rigidity or something like that, still it's okay, because what you need to understand, there is an intra-abdominal part of the esophagus as well, and all those particular stuff, widening of the mediastinum and so everything is kind of a picture perfect. This is what is a spontaneous perforation of an esophagus. Okay, I hope you have understood this particular point, guys. Okay, right. Now, okay, now if I ask you a couple of things about the esophageal cancer, like perforation, what is the most common cause? What is the most common cause? What is the most common cause of esophageal perforation? What is the most common cause of an esophageal perforation? It is iatrogenic. Okay, it is iatrogenic. So upper GI endoscopy. Okay, so upper GI endoscopy. When you're trying to kind of negotiate your scope through the the cricopharynx, okay, cricopharyngeus muscle, at that particular point of time, you can kind of end up injuring this particular esophagus. Okay, I hope you are able to understand this particular point. Okay, now I know that you have not covered, but let's kind of talk about what you call as your buoy reef syndrome and this Maltese syndrome and everything like that. Okay, so let's say if at all there is a patient who is having vomiting against closed glottis. Okay, so what you need to understand, normally when you vomit, okay, normally when you vomit, what happens is that the lower esophageal sphincter, the upper esophageal drain, everything kind of relaxes. Okay, but if at all, let's say there is a vomiting against the closed glottis, what is going to happen? There's going to be the increase in the pressure in the esophagus. Okay, there's going to be increase in the pressure inside the esophagus, and this particular increase in the pressure inside the esophagus can manifest in two forms. Either it can manifest as a through rupture of the esophagus, or it can manifest you as what you call as a longitudinal tear of the esophagus. Okay, so if at all there is a through and through rupture of the esophagus, that is what is leading to the perforation. Okay, so this is what is leading to the perforation. But if at all there is a longitudinal tear, in this particular scenario, what is going to happen? There is going to be the hematemesis, and now this is what is called as a Mallory Weiss tear. Mallory Weiss tear. Okay, so this is what is referred to as your Mallory Weiss tear, and through rupture of the perforation, this is what is called as a Boyer Heave syndrome. Okay, so through rupture of the esophagus, this is what is called as the Boyer-Heave syndrome, and the longitudinal tear of the esophagus, this is what is called as the Mallory Weiss tear. I hope you are able to understand this particular point, Boyer-Heave syndrome and the Mallory Weiss tear. So this is vomiting against the closed glottis. Okay, so this is what is your vomiting against the closed glottis. Okay, yeah, so somebody was trying to tell me about, okay, so I'm pretty sure that you guys know about this, but yeah, let's kind of talk about this. Okay, now there's a male patient who presented with the persistent abdominal pain. There was a less responsive to the medical treatment. Okay, that's fine. Along with the melena also happened, vomiting, perital irritation. On investigation, was found to have the fasting hypergastrinemia. Basal acid output was greater than blah blah blah. Diagnosis of the gastrinoma was made. What is the most common site of the gastrinoma in the Meniere's syndrome? So they have kind of given in the entire history of the test, stating that this is a patient with gastrinoma. In short, what they're trying to ask you is that what is the most common site of the gastrinoma? It is the duodenum, definitely. So what is this particular stuff? This is what is called as a, okay, so let me just talk to you about a bit about the gastrinoma. So what is this particular gastrinoma? This is like a benign or a malignant tumor. So please try to understand, this is what is your malignant neuroendocrine tumor of the pancreas. Okay, so this is the malignant neuroendocrine tumor of the pancreas. That is the first thing. Now what you need to understand is that this is the most common type of pancreatic neuroendocrine tumor in the MEN1 syndrome. Okay, if they ask you which is the most common pancreatic neuroendocrine tumor overall, then the answer is your insulinoma. But over here in the MEN1 syndrome, it is the gastrinoma. So if I ask you about the site, okay, so what is the most common site of this particular gastrinoma? So yes, it is what is called as a gastrinoma triangle or Passarose triangle. So what are these, like what are the points of this particular gastrinoma triangle or the Passarose triangle? So this is what you call as a gallbladder and the cystic duct, and then there is a second and the third part of the duodenum. So this is basically a triangle which is joining the what you call as a body and whatever the like the tail of the pancreas, then the cystic duct and the gallbladder, and then the second and the third part of the duodenum. So this particular triangle is basically called as your gastrinoma triangle. So what are the 3 points? I'm not writing it down, I'm just trying to tell you with this. So body and the like in the head and the body of the pancreas, then we have a second and the third part of the duodenum, then we have the point which is joining the gallbladder and the cystic duct. Okay, so these are the 3 points. If you join it, what you basically get is a gastrinoma triangle or the Passarose triangle. Now if at all, so what is gastrinoma? This is basically a Zollinger-Ellison syndrome. This is a tumor of the G cells. What is an investigation of choice? So you basically check for gastrin levels. Okay, you check for the gastrin level. If at all these particular gastrin levels are more than 1000, okay, if at all these particular gastrin levels are more than 1000, then it is diagnostic. It is diagnostic of your what you call as your gastrinoma. If at all the gastrin levels are less than 200, this is normal. This is basically present in any normal individuals. But if at all you have a gastrin levels which is basically between 200 to 1000, okay, so this is what is a gray zone. Okay, so this is what is a gray zone. Over here what you have to give is, you have to give secretin. Okay, so here you have to kind of give secretin, and after giving the secretin, if at all the basal acid output increases by more than 200, okay, if at all the basal acid output increases by more than 200, this is what is diagnostic. Are you understand my point? So please try to understand over here that secretin, basal acid output increases more than 200, this is diagnostic, and more than 1000 per se it is kind of diagnostic. So this is all about the gastrinoma. What you need to understand, the treatment is basically what you call as your surgical dissection. So you have to kind of perform a surgical dissection in these particular patients. Okay, now what you are dealing with over here, so this is what is your what you call as a, okay, so Child-Pugh's classification. Okay, so let's talk about the Child-Pugh's classification over here. So let's cover that up. Okay, so let's kind of cover your Child-Pugh classification. So this is important, so I'll just kind of walk you through it. So what are the components of the Child-Pugh classification? Okay, pretty simple. So you deal with ascites, you deal with encephalitis, cephalopathy. Then what do you have? You have the serum albumin. Then you have PT and INR. And then what you have? You have bilirubin. Okay, so these are the components which you basically have for the Child-Pugh classification. They sometimes ask you only the components, so please do remember the components as well: ascites, encephalopathy, albumin, PTINR, and the bilirubin. Okay, now you basically give them like the 1, 2, and 3. So what are the kind of values which you basically give them is the 1, 2, and 3. What about the ascites? No ascites, mild to moderate ascites, and the severe ascites. So no is basically 1, mild is 1, 2, and I'm pretty sure that you guys know that 1, 2, 3, and right? Okay, what about the encephalopathy? Again, the no, then there is mild to moderate, and then there is a severe. Now what about the albumin? Now what is the function of the albumin? Albumin basically should be more or less. What do you want? You want more albumin, right? So liver, if at all the albumin is normal, it means that it is more, right? If at all the liver function goes down, the albumin levels are going to go down. So if at all the albumin is more than 3.5, that is good. If at all it is basically 2.8 to 3.5, that is what is 2, and if it is less than 2.8, that is kind of bad. You understand my point? What about the PT and INR? If at all the liver function deteriorates, what is going to happen? The PT and INR are going to rise. So if at all it is less than 4, then it is 4 to 6, and then it is more than 6. What about the INR? It is less than 1.7, 1.7 to 2.3, and then more than 2.3. What about the bilirubin? Okay, so what about the bilirubin? Bilirubin is less than 2, then 2 to 3, then more than 3. Are you understanding my point? So these are the important things which you need to understand. I have deliberately written it so that you will try to remember it. Okay, so it's pretty simple. It's pure logic. Please try to understand over here. Now let's go to the question. So here what you have, that there is a patient who is having a serum bilirubin of 2.5. so this is 2. Then serum albumin was 3. So what is this? This is what you call as, so we had more than 3.5. So this is again 2. INR of 2, which is again the score is of 2. Mild ascites, this is again 2, and there is no encephalopathy, which is basically 1. So the score comes out to be 9. Now what they're trying to ask you, everybody understood it now? Everybody understood it? So how the score came out to be 9? Encephalopathy was basically no, but rest all was mild ascites. Then there was the albumin was 3. INR was 2, bilirubin was I think also 2.5. okay, bilirubin was 2.5. You're understanding? So the calculation basically comes out to be what you call as a 9. Okay, 9. Okay, so I hope you have understand. It comes out to be 9, and this is what is the Child-Pugh's criteria B. So how do you kind of remember this? So values of less than 5 is Child-Pugh's A, like 5 to 6 is basically Child-Pugh's A, 6 to 9 is basically B, and more than 9 to 15 is basically Child-Pugh's C. You understand my point? So please try to understand over here. This is what is your Child-Pugh's B. Okay, so this is what is your Child-Pugh's B. Everybody understood this point? So this is what is the Child-Pugh's B. Okay, please remember this, guys. This is an important classification. And what does this tell you? This basically tells you about the liver function. You also should remember about the Milan's criteria. What is the Milan's criteria? Okay, so what is the Milan's criteria, guys? Milan's criteria is basically that if at all there is a liver there is a hepatocellular carcinoma, so either there is only a single mass which is less than 5 centimeters, or there are multiple mass, or there are multiple mass which is less than 3 in number, and none of them is like more than 3 centimeters. So they are less than 3 centimeters and less than 3 in number. So these are the two things, and there should be no extra hepatic spread. Are you understanding my point? So please try to understand over here. Single mass less than 5 centimeters, 3 or less than 3 mass, none of the size more than 3 centimeters, and no extra hepatic spread. This is what is your Milan's criteria. So Milan's criteria basically tells us whether a patient with a hepatocellular carcinoma is an eligible candidate for the liver transplantation or not. So this is what you basically get to know in this. Okay, so I hope you have understood this particular point. Now, management of the renal cell cancer of less than 4 centimeter size. What is it? It is basically a partial nephrectomy. Okay, so now this is a question for, if at all they ask you, you have to mark this, that's fine. But this is a very bullshit question to be asked, because the decision. Okay, so what you need to understand is that, let's say if at all there is a kidney, and let's say so the decision whether to perform a partial or a radical nephrectomy is not dependent just on the size of the tumor. Are you understanding my point? So let's say if at all the size of the tumor is big, and it is kind of exophytic. It is predominantly exophytic. And even if there is a size of the tumor which is small, which is involving the hilum of the kidney. So in this particular scenario, you can perform a partial nephrectomy, but here you have to perform a radical nephrectomy. Are you understanding my point? So in the practical life, this is not good. But for you, all you need to understand, the size less than 4 centimeters is called as a small renal mass, SRM, small renal mass. And for the small renal mass, what you basically perform is a partial nephrectomy. Are you understanding my point? I hope you have got this point. Now, even according to the guidelines, this has been increased to 7 centimeters now. But as I'm trying to tell you, just focus on this, okay? So one of the indications is size less than 4 centimeters, small renal mass. The second is, let's say if at all there is a familial syndrome, von Hippel-Lindau disease or something, if at all the patient is having a single kidney, solitary kidney, all these particular things are there, okay? So I hope you are able to understand this point, okay? So in the practical life, the general dictum says that if at all the surgeon is skilled enough and if at all the mass is predominantly exophytic, you try to do a partial nephrectomy. And if at all you are able to preserve the kidney, that's fine. You perform a partial nephrectomy. If you are not able to do a partial nephrectomy, then you perform a radical nephrectomy. You understand? If at all it is more than 7 centimeters, then you will remove the entire kidney. If at all the mass is very big, you will remove the entire kidney. Yeah, that's what is a radical nephrectomy, right? I hope you have understood this particular point. Got it? Okay. Now, a chronic smoker presents with the pain, cramping in the legs, blah, 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 during the walking, blah, blah, blah. A patient typically has the pain after walking nearly 200 meters. The pain disappears at rest. The statement given condition is okay, true statement, okay? They are asking you the true statement. Felt at rest, okay? No, the pain is not at rest. Most common site is the calf, okay? Claudication distance can vary from day to day. Well, this is again false, because claudication distance is basically constant unless the disease is not progressing or something like that. Relieved after getting out of the bed and walking, no. It is exacerbated by walking. Once you take rest, the pain basically goes down. But yes, it is the most common site is basically the calf. So what we are talking about over here is a intermittent claudication, okay? So let me just kind of get back. Sir, when is the partial nephrectomy done if less than 7 centimeters? See, eagle eye, what you need to understand is that for you, according to the 11B, less than 4 centimeters is the partial nephrectomy. But what I'm trying to tell you is that just on the basis of size, we cannot decide. It basically depends whether in the, where in the kidney the tumor is there. But okay, forget about it. As in the exam, which is going to happen a couple of days later, they're not going to test you on that. For the exam, please try to understand less than 4 centimeters is a ideal indication for your partial nephrectomy, but according to the guidelines, they have extended into the 7 centimeters. So if in the options they give you, when will you perform, for example, hypothetical question, if they ask you, when will you perform a partial nephrectomy? Size of the tumor less than 7 centimeters, 10 centimeters, 13 centimeters, 16 centimeters, then you will have to mark it as a 7 centimeters. Are you understand my point? But according to 11B, they still mention it as a 4 centimeters. Okay, I hope you have understood this particular point. Okay, so my bad, I confused you guys, but yeah, I hope you have understood. We are not here to learn the practical aspects over here. We are here to prepare for the exam, which is going to happen a day after tomorrow. So yeah, my bad for confusing you a bit, but I hope you have understood it, right? Okay. Got it. Now over here, what we are talking about is an intermittent claudication. So what is this intermittent claudication? This is basically the cramp-like pain, which is basically occurring in the calf muscles when you walk. Okay, when you walk. Now here, there is a Boyd's classification. Okay, Boyd's classification, which is associated with this. What is this Boyd's classification? I'll just kind of talk about it. I will not write it because of lack of time. So Boyd's 1 is what? When you start to walk, you basically suffer from pain, but when you continue to walk, the pain basically goes away. That is what is a Boyd's 1. Why does this happen? Because when you continue to walk, what is going to happen? The local, whatever the local blood flow is going to increase, and that is going to wash out that particular CO2 and the metabolites and everything, and that is what is going to help you reduce the pain. That is what is a Boyd's classification 1. Okay, so that is a Boyd's 1. Okay, so revise Boyd's classification, that's what I'm trying to do. What is Boyd's 1? When the patient starts to walk, the patient gets pain, but when the patient continues to walk, the pain basically goes away. That is Boyd's 1. What is Boyd's 2? When the patient starts to walk, patient gets pain, but the pain is not very severe enough. So patient can still continue to walk. Okay, for example, at this point of class, this is kind of bearable with you guys, so that's why you're staying and watching it over here. But if at all this particular class becomes unbearable, then you will kind of go away, right? So in the similar manner, when the patient starts to walk, and if at all the pain is kind of bearable enough, the patient can still continue to walk. This is Boyd's 2. In the Boyd's 3, what happens when the patient starts to walk? Patient gets pain, but the pain is very severe. So now what you need to happen, the patient has to take rest. So when the patient takes rest, the pain basically comes down. You understand? Remember, this is Boyd's 3. What is Boyd's 4? It is rest pain. Even when the patient is sitting, the patient is having pain. This is what is a Boyd's 4. I hope you have understood. I hope you have understood the Boyd's classification. Okay, so this is all about the Boyd's classification, the claudication systems, and yeah, I hope you have understood. Now let's move on. Let's move on to the next question. So there's a 30-year-old male presents with a cramping gluteal pain after walking 500 meters. Which is the vessel involved. So again, as I told you, if at all there is a gluteal pain, it means that the obstruction is at the level of the iliac vessels. Okay, so obstruction is at the level of the iliac vessels. So arterial disease with the aortoiliac involvement. Okay, so yeah, answer is A. Okay, so please try to understand, because of the iliac vessels, the kind of the what you call as the gluteal muscles are not basically enough amount of pain. So here the erectile dysfunction can also happen over here in these particular patients because of the involvement of the iliac kind of vessels over here. And here, if at all you want to kind of perform, it is what is called as a aortofemoral bypass. Okay, so do you want me to cover ABPI? Okay, I'll cover an ABPI. Okay, so what is ABPI? ABPI basically means ankle brachial pressure index. So guys, if I ask you that, you know what, that if I kind of measure the blood pressure in my arms, and if I measure the blood pressure in my legs, and if I take the ratio of it, what is going to happen? It's going to be the same, right? It's going to be same, but like it's going to be somewhere between 0.8 to 1 or something like that, or 0.1 to 1.1. That is what is going to be there. So what you basically do with this, let's kind of talk about that first. Okay, so what you basically do in this is that you measure the pressure in the ankle. How do you measure the pressure in the ankle? So which is the vessel in which you measure the pressure in the ankle? So you measure the pressure in the dorsalis pedis artery or the posterior tibial artery. So you measure the pressure basically in the dorsalis pedis artery or the posterior tibial artery. So these are the two places where you can measure the pressure. So this is what is your ankle pressure. Okay, and then we also measure the pressure in the brachial artery. Measure the pressure in the brachial artery. So yeah, that is what is in the brachial artery. That's fine. Okay, then what you do, you take the ratio of it. Okay, then you take the ratio of it. That is what is called as an ABPI. That is basically ankle to the brachial. Okay, so this is what is your ABPI. Everybody got this? Okay, now let's talk about the values of this. Okay, so what is a normal ABPI? Okay, so when you talk about the ABPI, what is a normal? The normal is basically between 0.8 to 1.1. Somebody has written 1.3. No, it's not 1.3. If at all the ABPI is more than 1.1, okay, this basically tells you that there is an uncontrolled diabetes mellitus with calcified walls. So guys, you have not yet been tested over this, but in the foreign exams, for example, MRCS and everywhere, this has been tested quite a lot. So what they basically give you, that there's a patient who is having a intimate claudication, blah, 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 all these things that they're going to give you. And they give you that the ABPI is 1.3 or 1.2 or something like that. And then they ask you what is the probable possibility of that. So the reason is because the patients might be having an uncontrolled diabetes mellitus. Because of that, the calcification of the vessel wall has taken place. And now it's taking a lot of pressure for you to kind of compress these particular vessel walls, giving you falsely elevated blood pressure. You understand my point? So this is what is your ABPI more than 1.3. If at all it is less than 0.3, this is what is called as a critical limb ischemia. Okay, so this is what is called as a critical limb ischemia. If at all the ABPI is less than 0.3, this is what is a critical limb ischemia. If at all it is let's say 8 or 0.7 to 0.5, this is what is the patients are going to have mild symptoms. And if at all there is a 0.4 to 0.5, this is what is going to be a severe symptom. So this is not important. All that is important is what is the normal value. Normal value is 0.8 to 0.1, 1.1. If at all the value is less than 0.3, this is what a critical limb ischemia, where there can be necrosis, gangrene, all those particular stuff. If it is more than 1.5, it means that you're dealing with a patient with an uncontrolled diabetes mellitus with a calcified vessel walls. Okay, I hope you are able to understand these particular stuff, guys. Okay, so this is about the ABPI. Now let's move on to the next question. The patient presented with the halitosis. Halitosis means the bad odor, bad breath, everything. It's one of the simplest questions ever. With the lateral aspect, blah blah blah, giving rise to a regurgitation of the air sound. Barium image has been shown to you. What is the diagnosis over here? What is the diagnosis? What is the diagnosis? The diagnosis over here is, yeah, so this is the pharyngeal pouch, that is the Zenker's diverticulum. So Sandeep GV is basically asking that, you know what, 0.3 or 0.4. So please try to understand, it is less than or equal to 0.3. Less than or equal to 0.3, that is what is your critical limb ischemia. Less than or equal to 0.3, that is what is your critical limb ischemia. Okay, got it? Okay, right. So understood, right? So yeah, this is what is your, what you call as the pharyngeal pouch or the whatever this. Okay, now what do you need to understand over here? I'll just kind of quickly walk you through it about. So what is happening over here, that is the cricopharyngeus muscle is not able to kind of relax. So there is what is an outpouching from the Killian's triangle or the Killian's diasis. From there, the outpouching basically there. It starts posterior in the midline, then it comes to lie on the left side. That's all just fine. What is the investigation of choice? Investigation of choice is your barium swallow. Barium swallow, that is what is the investigation of choice. What are the complications which can occur? So complications which can occur is a like a lung abscess. Okay, so over a period of time, lung abscess can also occur, because whatever the old food which is basically lying into this particular pharyngeal pouch, it can get regurgitated into the lungs and everything. So lung abscess can happen. Now one of the important procedures or the surgeries which you can do over here, so can you please tell me the named surgery which is associated with this? So this is what is called as a Dollmann's procedure. Okay, so please try to understand, this Dollmann's procedure is basically for your Zenker's diverticulum. Okay, so here what we have is a Zenker's diverticulum. Zenker's diverticulum, we have a Heller's myotomy. कहाँ से आ गया छोटे doctor? So Heller's myotomy is basically for your what you call as your achalasia cardia, but here we are dealing with the Zenker's diverticulum. So here there is a Dollmann's procedure. Okay, so there is a Dollmann's procedure. Now anybody, can you tell me where do you perform this Delorme's procedure? Delorme's procedure. So Delorme's procedure is basically done for what? Can you please help me with this? Delorme's procedure is done for, so Delorme's procedure is basically done for, put it in the comment box, I'll write it down later. Okay, so yeah, a patient came to you with a progressive dysphagia involving both the fluids and the solids and the regurgitation, blah blah blah. It's one of the simplest kind of a thing. So what is this? This is what is your bird's beak appearance, rat tail appearance, whatever you want to call it. This is what is an achalasia cardia. Okay, achalasia cardia. Okay, no, it's not the ENT which is merged. Okay, yeah, it's a false diverticulum. Zenker's diverticulum is a false diverticulum. So guys, Delorme procedure is basically for your rectal prolapse. Okay, so we have DART, that is Delorme, Altmaier and the Thiarch. Okay, so this is Delorme, Altmaier and Thiarch. So all these are the perineal approaches for your rectal prolapse. This has also been asked as an MCQ, guys. Please try to understand. Okay, please remember this. Okay, so this D is Delorme, Altmaier and Thiarch. These are the three procedures which are the perineal approaches for your rectal prolapse. Okay, got it? Abdominal procedure as well, and there is a Ripstein's procedure, which is your abdominal procedure. Okay, can you please give the algorithm approach for the breast is under for approach for the breast 25 minutes. Okay, limo, I'll try to do that. Okay, I'll try to do that, just give me a minute. Okay, got it? Okay, right. So this is what you need to understand. Achalasia cardia is kind of simple, that's fine. Can we move ahead with that? Okay, okay, so poem. Okay, what is this particular poem? Poem procedure is used for? Poem procedure, yes. Epstein is the abdominal, right? Good. Okay, so poem procedure is used for your achalasia cardia. Okay, there is something which is called as a stir procedure. Now this is given in your new edition of the 11 Billy. Please remember the STIR procedure is basically used for your esophageal leiomyoma. Okay, so this is basically used for your esophageal leiomyoma. Please try to understand over here. Okay, got it? Okay, got it. Okay, right? Okay, now a 20-year-old boy is brought to the emergency after the road traffic accident with the respiratory distress, hypotension, subcutaneous emphysema, physical examination, no air entry on the right side. What is the next best step in the management of this particular patient? So what do you think? What is the answer? What is the diagnosis over here? The diagnosis over here is a, what do you call as a tension pneumothorax. Okay, what is the diagnosis over here? It is a tension pneumothorax, and what you're going to do over here, you are basically going to perform a needle decompression in the fifth intercostal space in the mid axillary line, because here we are dealing with an adult 20-year-old kind of a boy. Okay, but if at all, let's say it was a child, then we would have performed in a second intercostal space in the mid clavicular line. Okay, so I hope you've understood. This is what is your tension pneumothorax. Okay, now a patient presented with the peritonitis during the surgery for the diverticular perforation, and there was a fecal peritonitis. Okay, so what is the Hinchey's classification? So can you please help me? What is this Hinchey's classification? 1, 2, 3, or 4? So this is what is the type 4 Hinchey's classifications. Okay, so let's cover a bit points about your diverticulitis. So if I ask you, colonic diverticulum. Okay, so let's talk about the colonic diverticulum. It is colonic diverticulum. They are more common on the left side or the right side. So please try to understand they are more common on the left as compared to that of the right side. So left sided colon, sigmoid colon is the most common site of your whatever is the colonic diverticulum. If I ask you investigation of choice for your diverticulosis and investigation of choice for your diverticulitis. Okay, so first of all, are they the same or different? So please try to understand over here. The investigation of choice for your diverticulosis is your barium enema. Okay, here what you basically get is a sawtooth appearance. What about the diverticulitis? This is CECT. Okay, so please remember this. Okay, don't have a knee-jerk response. As soon as you see this particular sawtooth appearance, don't mark it as a diverticulitis. For the diverticulitis, the investigation of choice is your contrast enhanced CT scan. Very, 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 very important. Okay, I hope you have understood this particular point, guys. Okay, now in the diverticulitis, what you basically have is you have what you call it as a you have something which is called as a Hinchey's classification. So here what we have is type 1 is basically your pericolic abscess. In the type 2, what is there? There is a pelvic abscess. In the type 3, there is purulent peritonitis. And in the type 4, there is a feculent peritonitis. Are you understand my point? So we have a pericolic abscess, pelvic abscess, purulent peritonitis, and the feculent peritonitis. I hope you are able to understand this particular point. Very, 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 very important. Okay, so rule of 2 is not for this particular colonic diverticulum. Nazir Sheikh, rule of 2 is basically for your Meckel's diverticulum. Okay, so that is different. Meckel's diverticulum is a true diverticulum. Colonic diverticulum is basically your false diverticulum. So diverticulosis is your false diverticulum. Meckel's diverticulum is your true diverticulum. This is what is occurring on the mesenteric border. That is what is occurring on the anti-mesenteric border. Okay, I hope you have understood. Everything is kind of different. Now here, T half of the PTH, it is around 7 to 8 minutes. Okay, 7 to 8 minutes is the T half of the PTH. So what happens is there should be 50% reduction within the 10 minutes. And this is what is called as a Miami criteria. Okay, so this is what is called as a Miami criteria. Okay, so please try to understand over here. This is what is a Miami criteria, where you basically look for the reduction in the PTH levels. PTH levels should come down by 50% within 10 minutes, because the T half of the PTH is 7 to 8 minutes. Okay, so this is intraoperatively knowing whether you have done the good job or not, or something like that. Okay. Screen stuck, sir? No, I don't think so. Screen is stuck. I think there is issue on your end, Nazir. Okay, so I think it's the issue on your end. Okay, so please try to understand this. Okay, now what you need to understand over here, that there is a patient who is having a dysphagia and the esophageal manometry was performed. It revealed that there is an abdominal spastic contractions, esophagus, the pressure basically goes beyond 450 mm of Hg. What is the diagnosis over here? So please try to understand here what is the diagnosis. Diagnosis is type 3 achalasia. Okay, so what is it? It is a type 3 achalasia. Okay, please try to understand over here. So this is a table which you should understand. So there are two terminologies, which is basically the DCI and IRP. IRP is integrated relaxation pressure. DCI is distal contractile integral. So this is what is a part of your high resolution manometry. In order to diagnose the patients, in order to kind of make the diagnosis of an achalasia cardia, what you need to understand is that the IRP should be more than 15. It has to be kind of there. Elevated median IRP, integrated relaxation pressure, should be more than 15 millimeters of mercury. That is kind of given in all the three. But if at all the DCI, distal contractile integral, is more than 450, then it is a type 3 achalasia cardia. Over here it is less than 450. Okay, so this is less than 450, but if at all it is more than 450, this is what is a type 3 achalasia cardia. So what happens in the type 1? Type 1, there is no peristalsis, there is no pressure, nothing is kind of there over here. In the type 2, what is there? There is a pan-esophageal contraction, but that is basically there is but there is no effective peristalsis. But over here in the type 3, what is there? That there is a segmental contraction. So there is a premature contraction, there is a segmental contractions of the esophagus, and that is why whenever you perform this what you call as a Heller's cardiomyotomy and everything, they are most effective in the type 3 achalasia cardia. Okay, right? Understood? Right? So Eagle's Eye, I think around 8 questions are left. Okay, so we'll be able to cover it in, let's say, 15-20 minutes, 20-25 minutes or something like that. Around 8 to 9 questions are left. Okay, got it? Okay, right. Now, okay, let's talk about this. So a patient presented with a lump in the breast. She was diagnosed with the stage 3, blah blah blah. Modified radical mastectomy was done. Now you want to kind of what you call as do a breast reconstruction. What is the answer over here? Can you please help me with this? Okay, so the answer over here is C. Okay, so what is this? DEIP, flap. Okay, so this is basically a free flap, free tram flap. This is what is a DEIP flap. So this is DIEP, sorry. Okay, so the DIEP, deep inferior epigastric vessel. So this is basically based on deep inferior epigastric pedicle flap. So this is what is a type of your free flap. This is the best flap which you can have in the patients for the breast reconstruction. Are you understand my point? So yeah, DIEP flap. Okay, got it? Okay, so yeah, I'll not cover everything. So this is what is a pedicled tram flap. This is what is a free tram flap. What you're basically seeing over here, pedicled tram flap. This is basically based on the superior inferior epigastric vessel. This is what is a free flap, where you basically take the skin and the fat also along with it. So this is the best kind of replacement for the breast and all this particular stuff. DIEP flap, important. Okay, I hope you remember this. This is an LD flap which was basically done earlier. This so we do not do at all. LD flap, it was done earlier. Latissimus dorsi was kind of taken, but that is kind of way back. Now we do not prefer to kind of do this particular stuff. Okay, yeah, got it? Okay, now let's say a baby is kind of born, bowel, blah blah blah. So what is the diagnosis? One of the simplest questions ever. So this is what is your gastroschisis. Okay, so this is what is your gastroschisis in the okay, so this is not from this particular second best will be your pedicle tram flap. Okay, got it? Okay, right. So what you need to understand over here, that in these particular patients, so yeah, here this particular bowel is not coming out from the umbilicus, it is basically coming from the left of the umbilicus. That is one thing. And yeah, pretty simple, nothing major about this. What about the congenital anomalies? Congenital anomalies, they are more associated with the gastroschisis or the omphalocele. So they are more associated with the omphalocele. So in the omphalocele, you might feel that the intestine is basically well protected inside that particular membrane and all those particular stuff. So yeah, like probably it would be kind of good, right? But what you need to understand, there the patients are having some kind of cardiac defects, cleft palate. So multiple congenital anomalies are associated with an omphalocele. The prognosis overall is less in the omphalocele. Gastroschisis, the problem is the intestine. But if at all you're able to manage the intestine, that's kind of done. No other congenital anomalies are present in these particular patients. So please try to understand. Cleft lip, cleft palate associated with omphalocele. They're not associated with the gastrochisis. Okay. I hope you have understood this point. Okay. Okay. Right. Now let's talk about a patient presented with the dyspnea. So there's a patient who is presenting with the dyspnea. So what you need to understand over here, just give me a minute. There's a bit of a technical issue. Just give me a minute, guys. Just give me a minute. Okay. Yeah, so what I was trying to tell you, yeah, so here there is a patient presented with the dyspnea and choking sensation of the cuff and whatever it is, fascia, blah blah. X-ray revealed that there is a mediastinal mass. The patient had a hyperthyroidism, the nuclear blah blah blah, thyroid activity in the mediastinum. Okay, so basically they are trying to tell you that there is a retrosternal goiter and there is a retrosternal goiter and explain the incisions. Okay, I'll do that. Okay. Okay, Xenon is asking most commonly from the left or the right. Okay, so you're talking about the gastrochitis, is it? So it is mostly from the right side of the umbilicus. Okay, so gastrochitis is mainly from the right of the umbilicus. Okay. Got it? And over here, what you, okay, incisions. Yeah, I'll be talking about the incisions. Okay, so just give me a minute. It is not the thymoma, it is a retrosternal goiter which we are talking about. So they have given you everything, right? That they're giving you that the thyroid activity in the mediastinum, nuclear thyroid scan, everything. So yeah, the answer over here is what you call as a, yeah. So origin is from the mediastinum. Okay, which of the following statement is true regarding the given condition? Sternal incision is always required. Majority of the goiters derive the blood supply from the mediastinal vessels. Majority of the resistant goiter are removed from the neck incision. The answer is over D. Okay, so I will just kind of cover this particular stuff with you guys. Okay, so let's talk about the retrosternal goiter. Okay, what about the retrosternal goiter? What is a retrosternal goiter? Retrosternal goiter is basically a condition where more than what you call as more than 50% of the thyroid tissue is basically present inside the what you call as a mediastinum. Okay, so what is a retrosternal goiter? When do we say that there is a patient who is suffering from a retrosternal goiter? When more than 50% of the thyroid tissue is basically present inside the mediastinum. Okay, so what you need to understand, there can be either a primary retrosternal goiter or there can be a secondary retrosternal goiter. So what do you understand with the primary? What do you understand with the secondary? Primary means that it started its development inside mediastinum only. So in the primary, what you need to understand, it started the development in the mediastinum. But what about in the secondary? It started the development in the neck and then it came to lie into the mediastinum. So it started development in the neck and then it come to lie in the mediastinum. Now if at all there is a primary retrosternal goiter, what do you think about the blood supply? So here what you need to understand, the blood supply is mainly from the mediastinal vessels. Okay, so mediastinal vessels se hi aa jayega blood supply in the primary retrosternal goiter. In the secondary retrosternal goiter, what you need to understand, it is basically from the neck vessels. Okay, so the neck vessels are basically supplying the blood supply to this secondary retrosternal goiter. Now can there be a parasitic blood vessels formation in the secondary retrosternal goiter? Yes, there can be parasitic blood vessels, but most of the times it is the neck vessels which are basically supplying to the secondary retrosternal goiter. If it grows too big, then yes, the parasitic vessels may come from the mediastinum as well, but primarily it is from the neck vessels. Okay, now out of these two, which is more common? So please try to understand, the secondary retrosternal goiter is much more common. It is 95% and this is around 5%. And that is why if at all you want to operate on these particular patients in the primary retrosternal goiter, because they have started the development in the mediastinum and they're getting the blood supply from the mediastinal vessels only, here you have to perform a thoracotomy, sternotomy, thoracotomy, whatever you want to call it. But over here, what you need to understand is that because the majority of the blood supply is from the neck vessels only, so you can put a cervical incision and you can basically take control of the blood vessels and you can remove the thyroid from here itself. Okay, you understand my point? Now this particular question is inadequate because it doesn't tell you whether you are dealing with the primary or the secondary retrosternal goiter, but it is assumed that 95% of the secondary retrosternal goiter, so it is assumed that you are basically asked about the secondary retrosternal goiter. You understand my point? So origin from the mediastinum, this is for the primary. Sternal incision is kind of required. Again, it is for the primary. Majority of the goiters derive the blood supply from the mediastinal vessels. This is again for the primary, but yeah, majority of the retrosternal goiters are this is a secondary because it is 95%. Okay, this is the winning. It is having 95%, and that is why that is the answer. Okay, but if just because they have asked you this particular question, please try to understand. If at all they ask you that what is the preferred incision for the primary retrosternal goiter, then it is going to be a sternotomy or it is going to be a thoracotomy, whatever you want to call it. Okay, I hope you are able to understand. Now, how will the patients present to you? Compressive symptoms, dysphagia, respiratory distress, and all those particular stuff. And yes, Pemberton signs. So what is this Pemberton sign? This is basically a provocative sign. When the patient comes to you, the patient is absolutely fine. What you do, you ask the patients to kind of lift both the hands above the kind of head and everything. So the space basically reduces and there is a characteristic facial plethora. So Pemberton sign is again associated with the retrosternal goiter. I hope you have understood this point. So whoever was trying to ask me about the incisions, I hope you have understood this particular point, guys. Okay. Now, this is a question which is important. I'll come to this particular question at the last question. I'll be discussing this. Okay. Now, which of the following is the most common pancreatic neuroendocrine tumor? We have talked about this. This is an insulinoma. Okay. So overall, what is the most common pancreatic neuroendocrine tumor? It is an insulinoma. But if at all we talk about the MEN1 syndrome, in the MEN1 syndrome, it is a gastrinoma. Okay. Now, one thing which you should remember about the insulinoma is, what is the triad which is associated with insulinoma? Can anybody tell me? So it is a Whipple's triad. Okay, so please try to understand. Whipple's triad is the one which is associated with the insulinoma. What happens in this particular Whipple's triad is that there is features of hypoglycemia. The patients are having the blood glucose level which is less than 50, and when you give the glucose to these particular patients, the symptoms basically settle down. So this is what is the Whipple's triad, which is basically associated in the patients with insulinoma. If I ask you for the insulinoma, what is an investigation of choice? It is a 72-hour fasting glucose. Okay, so this is a 72-hour fasting glucose. This is a benign condition, and this is something which you should remember, that if at all we have a pancreas, what is the distribution? Where is it present mainly? Head, body, or the tail? So please try to understand it is equally distributed in the head, body, and the tail. So 1/3 is basically present in the head, body, and the tail of the pancreas. Okay, I hope you have understood. I'll not cover the insulinoma in complete details, but yeah, these are the few of the important points about it. It is a benign condition, and this is what the most common pancreatic neuroendocrine tumor. Okay, now patient presented with the emergency with the stab injury to the lower chest and the lower pulse, BP kind of improved after whatever the IV resuscitation. The X-ray shows a clear lung field. Next step in the management of this particular patient, chest tube insertion, CCT abdomen, CCT kind of chest, or the EFAST. Yes, you have to perform an EFAST. If at all you want to perform the next step in the management of this particular patient, you have to perform an EFAST. Okay, so what you have to perform? You have to perform an EFAST. You understand my point? Got it? EFAST, right? Okay, let me just see whether I'll be okay. Okay, now, okay, what about this? So elderly female, blah, blah, blah. History of a hysterectomy 3 years back, presented with a colicky abdominal pain with the bilious vomiting. On examination, there's a tenderness in the abdomen, increased kind of peristalsis. X-ray of the abdomen revealed air in the bile tree and multiple air fluid levels. So what is the diagnosis over here, guys? What is the diagnosis? Why not CCT? Okay, so okay, just give me the answer to that. Okay, so here they have asked you next step. Okay, if at all they had asked the best step, then out of these particular options you would have asked the CCT abdomen. It's fine, but they have asked you the next step, so that is why the answer is EFAST. Okay, got it? Okay, next step is always the EFAST. Best is basically CCT. Got it? Okay, so what is the answer over here? It is a gallstone ileus. So very good. So what is a gallstone ileus? So what happens is that, let's say if at all there is a let's say this is a gallbladder, and inside the gallbladder, let's say there is a gallstone. What can happen over a period of time? It can erode through this particular gallbladder and can enter into the intestine, and then it can travel down. Okay, it can travel down and it can basically cause an obstruction at some distal part. So please try to understand here. What we basically get is a Wriggler's triad. Now I fail to understand what do they find in these particular stuff, but they keep on asking you this. Regular striad is seen in gallstone ileus, regular striad is seen in gallstone ileus, Whipple striad is seen in insulinoma, Whipple striad is seen in insulinoma. They have asked you so many times, okay? So please try to understand what are the components of this particular regular striad. We have talked about this, but yeah, what are the components of this particular regular striad? So this is intestinal obstruction, along with this pneumobilia, that is air inside the kind of gallbladder, and then what else? There is an ectopic gallstone. So all these are the features of your regular striad. I hope you are able to understand. What was the regular sign? What was the regular sign? Where did we talk about the regular sign? Regulars. This is a regular striad, that's fine. But we talked about the regular sign, right? So regular sign we talked about in the pneumoperitoneum, in the perforation, okay? So in the perforation, what we get is a regular sign. Over here, what we basically get is a regular striad, okay? So I hope you are able to understand this, okay? Okay. Right. Okay, I hope you have understood this particular point. Okay, now 85-year-old patient with the carcinoma of the prostate, 2 into 3 centimeters, called Gleason score C. Try to understand. So they do not expect you to know the management of the CA prostate. They do not expect you. The management of the CO prostate is changing like so rapidly. So I deliberately put this particular question over here because see, all you need to understand whenever you get a patient with a CA prostate, all you need to understand is that whether this particular patient is going to stay alive for the next 10 years or not. So you have to look at the age of the patient and you have to look at the what you call as a physiological age of the patient. You understand my point? So whether the patient is physically fit or not, or rather the life expectancy. If at all you feel that the patient, by reading at the clinical scenario, if you feel that the patient will stay alive for more than 10 years, then you can provide these particular patients with a radical prostatectomy, radical surgery and everything. But if at all you feel that, you know what, the patient might not survive for more than 10 years, then you have to go ahead with the active surveillance. You understand my point? So why this discrimination? You don't like the old people, you want them to kind of just die? No, not really. So what you need to understand is that the prostate cancer is a slow growing cancer. It's a slow growing cancer. So what you need to understand is that in next 10 years, it is very unlikely that the prostate cancer will actually kind of kill somebody. You understand my point? So in these scenarios, what you basically do is that if at all the life expectancy of the patient is more than 10 years, then what you do is that you tell the patient that, you know what, let's kind of get a surgery done. Now, frankly, what in the questions they, for example, this 85 years, okay, this is too big, but let's say 75, as somebody is kind of given in this particular, what you call as, like in the question in the comment box, they have given you about the 75 years, right? But this is just the physiological age, right? So you understand my point? So what we need to focus on the physiological age, whether the patients are going to stay or not. You understand my point? So like if at all the patients are going to be alive for more than 10 years, if at all the life expectancy is more than 10 years, then you have to kind of perform a radical prostatectomy. But if not, then you have to perform an active surveillance. Why not brachytherapy? So please try to understand brachytherapy is also kind of a giving a treatment. You understand my point? So it's not like that you cannot give a brachytherapy, but here you have to kind of perform an active, see, try to understand. As I told you that there are n number of managements for the prostate cancer. Radical, frankly, there's a radiotherapy is there and all those particular things are there. But at your level, or even if you ask a final year surgery resident, he or she will have absolutely zero clue how do you manage a patient with a prostate cancer. You understand my point? It's so rapidly changing and it is so vast. So at your level, all they want you to understand is in this particular question, they're actually trying to tell that, you know what, whether this particular tumor is a slow growing tumor or an aggressive tumor. So you understand my point? So if at all the physiological age is given kind of less, or let's say the age has been given 77, 65 or something like that, then you can perform a radical prostatectomy. But if at all they give you 80, 85, 90, 95 years, then you have to perform an active surveillance. Please try to understand this particular point. Okay, now let me just cover this particular question, then I'll kind of answer all your doubts and everything. So yeah. So a man has been brought to the emergency after he fell into the manhole, injured in the perineum. He feels there's an urge to micturate, but unable to kind of pass urine. There is a blood at the tip of the meatus and extensive swelling in the penis and the scrotum. What is the location of the injury of this particular kind of stuff? Okay, so what is the location? Can you please help me? What is the diagnosis over here? What is the diagnosis? What is the location of the injury in this particular patient? Can you please help me with this? bulbar urethra. Okay, yes, got it. Okay, but okay, can it be a bladder rupture? So try to understand. What I'll do is I'll just kind of talk to you about a bit about this. Okay, so what you need to understand, that whenever there is a patient who has come to you with a urological trauma, okay, so whenever there is a patient who is coming to you with a urological trauma, okay, so whenever there is a patient who is coming to with a urological trauma, what you need to understand over here is that you have to see whether the patient is having the urge is present or not. Okay, urge means that whether the desire to go and pass the urine has been present or not. So if at all the urge to pass urine is present, okay, then you are dealing with a urethral injury. You are dealing with a urethral injury. If at all the urge to pass the urine is not present, then you are dealing with a bladder rupture. Okay, so please try to understand why you and I kind of go and pass the urine. Why? Because why do we feel like going and passing the urine? Because what happens is that, okay, so I'll explain this in detail, don't worry. So why you and I like go and pass the urine? Why do we have the sensation of going and passing the urine? Because what happens is that when the bladder fills up, then the sensation goes to the brain and we have that urge, and then the brain basically sends a signal back, and then we go and pass the urine. So this is what is called as an urge to pass the urine. If at all the bladder has ruptured, now what is going to happen? The bladder will not get filled. If at all the bladder is not going to get filled, what is going to happen? There's going to be no urge to pass urine, and that is what you need to understand over here. So it doesn't matter whether it is an extraperitoneal or an intraperitoneal bladder rupture, but there's going to be no urge to pass urine in the bladder rupture. Frankly, this blood at the tip of the meatus, it means absolutely nothing. Okay, this absolutely means nothing. Many people make the diagnosis of the urethral injury and bladder rupture based on this blood at the tip of meatus. It's absolutely bullshit. It means absolutely nothing. All you need to understand is that whether the urge, okay, so if at all there is a urethral injury, so bladder is getting filled, but there's a pathway of that urine. The urethra is basically obstructed. Are you understand my point? So that is the reason what you need to understand. First thing is urge to pass urine present. Then what you need to understand, this is what is your urethral injury, no urge to pass urine, that is what is a bladder rupture. Now quickly let's talk about the extraperitoneal and an intraperitoneal bladder rupture. So what you need to understand with an extraperitoneal bladder rupture, in this what you basically have is that you have pelvic fracture, you have what you call as a deep perineal hematoma. So what you basically have is you have a pelvic fracture, you have a deep perineal hematoma. These are the things which you basically have in the extraperitoneal bladder rupture. And in this, the management is basically Foley's catheterization. So what you basically put, you put Foley's catheter and you keep it for around 10 to 14 days. So when you put the Foley's catheter, what is going to happen? The edges of the bladder which have got ruptured, they are going to come closer to each other, and now the process of the healing can take place. Are you understand my point? So this is about the extraperitoneal bladder rupture. Yes, molar tooth sign is basically seen on the CT scan, and on the cystogram, the image is also important. Just have a look at that particular image. What about the intraperitoneal bladder rupture? In the intraperitoneal bladder rupture, what you need to understand is that they will not give you that there is a pelvic fracture. They will give you that there is what you call as like there is either a penetrating injury, or they will give you that, you know what, there is a trauma with an over distended bladder. Okay, so there's a trauma with an over distended bladder. Are you understanding my point? Yep. Are you understanding my point? Okay, I'm coming to the other stuff. Okay, so please try to understand over here. If at all they give you that there is a penetrating injury or there is a over distended, for example, once they had asked you that the patient is alcoholic, after having a lot of alcohol, patient went to the washroom and patient fell down. So what they're trying to tell you, that alcohol is a diuretic, so there was an over distended bladder. When the patient went to the washroom, patient fell down, there's an intraperitoneal bladder rupture. Are you understand my point? And over here, what is going to happen when you are going to do the abdominal examination? When you're going to do an abdominal examination, you are going to find peritonitis. Okay, so peritonitis is going to be present in these particular patients. Are you understanding my point? Peritonitis are going to be present in these particular patients. Okay, so this is what you need to understand over here. Peritonitis is present. This is what you need to understand about the intraperitoneal bladder rupture. I hope you have understood this particular point, guys. Yeah, I hope you have understood, right? Okay, now what about the management? So if at all there is an intraperitoneal bladder rupture, the management is always going to be exploratory laparatomy. Okay, everybody have understood about the bladder rupture, guys? I hope you're able to understand this point. Okay, okay. Fetal skull sign is not seen over here. Okay, so the fetal skull sign is basically seen in the malakoplakia. Okay, that is basically the calcification of the bladder wall. Malakoplakia. There you basically see the fetal skull sign. Okay, please try to understand over here. Okay, right. Okay, now let's talk about the urethral injury. Okay, so let's talk about the urethral injury. It's a very, very important kind of a stuff. So let's say if at all there is a patient who is coming to you after the road traffic accident, and the patient is having an intense desire to pass urine, but patient is not able to pass urine, not able to pass urine. And I tell you that there is a over distended bladder. Okay, there is an over distended bladder. What I'm trying to ask you, what is the next step in the management of this particular patient? I want you guys to answer. So can you please tell me, if at all there is a scenario like this, after the road traffic accident, there is a patient who is having an intense desire to pass urine, but patient is not able to pass urine, and like there's an over distended bladder. What is the next step in the management of this particular patient? Can you please help me? What is the next step in the management of this particular patient? Yeah, what is the next step in the management of this particular patient? Come on, guys, come on. What is the next step in the management of this particular patient? I'll give you the options. SPC, RGU. Okay, very good, very good. Shimu is absolutely right. The next step in the management of this particular patient is RGU, and the SPC, suprapubic catheterization, the black pepper slayer, DG, Nazir Sheikh, all these guys who have answered. I'm not trying to kind of name you guys. What you need to understand, this is the most common wrong answer. Why I'm taking your name? So that you will remember. Please try to understand. Suprapubic catheterization is the most common wrong answer which you guys mark. The answer over here is a retrograde ureterogram. So when you perform a retrograde ureterogram, now you get to see whether there is any leak present of the contrast, or there is leak which is absent. You understand my point? So leak means that whether there's an, like from the urethra, whether the contrast is basically going outside the urethra or not. So if at all the leak of the contrast is kind of present, then what you can perform, now you perform an SPC. But if at all the leak is absent, now you perform a Foley's catheterization. You keep it for around 3 to 5 days, and then you kind of remove it. You understand my point? So yeah, so this is what I was trying to talk about. Sheetal is saying, sir, one gentle attempt of a Foley's can be given. See, try to understand. Now at your level, the next step is definitely RGU. Now there are few guidelines. Okay, there are few guidelines which basically say that a single gentle attempt of the catheterization can be done. But the drawback of that is that if at all there is a partial injury, you might end up converting it into a complete injury. So that is not done. For your level, it is not done. Are you understanding? If they don't mention RGU in the option, and if they mention that there is a single gentle attempt of the catheterization, you can still do that, not an issue. But if at all they have given you RGU, and along with that the other option is a single gentle attempt of the Foley's catheterization, do not mark that. Then your answer is definitely going to be RGU. Am I like, did you understand, Sheetal? I hope you have understood this particular point, right? So the next step is RGU, and if they don't mention the RGU, and if they say that the single gentle attempt of catheterization, you can still mark that, not an issue. That is given in few of the guidelines, that's okay, but that is not preferred. The drawback is because you might end up converting the partial injury into a complete injury. So how to differentiate? I'm coming to that, guys. Aditya, I'm coming to that. Just give me a minute, okay? What if the bladder not filled? There's a okay. So there's a chance that the patient is having the urge to pass urine, but the bladder is not filled. That's okay. That's not an issue at all. But if at all there is a patient who is having a road traffic accident, after that the patient is having the urge to pass urine, and the patient is not able to pass. For example, the patient is very, very obese. You will not feel the bladder. It's okay. You have to perform an RGU. Urge to pass urine, that has to be kind of looked for in the history guide. Okay, I hope you have understood, right? Got it? Yes. Okay. Now, finally, how do you distinguish between the anterior urethral injury and the posterior urethral injury? Okay, so let's talk about the anterior and the posterior urethral injury. So what? Okay, so first let's talk about the posterior urethral injury. What are the features which you're going to get in the posterior urethral injury? There's going to be the pelvic fracture. So there's a pelvic fracture. There is a deep perineal hematoma. On the digital rectal examination, the prostate is high riding or not palpable. This is what is called as a Vermuten. Okay, so this is what is called as a Vermuten sign. So if at all they give you all these particular stuff, then you are dealing with basically the posterior urethral injury. Are you understand my point? Pelvic fracture, deep endal hematoma. On digital rectal examination, the prostate is high riding, not palpable. Along with that, the patient is having a severe desire to pass urine, but the patient is not able to pass urine. So this is what is a posterior urethral injury, which is your prostatic urethral injury or a membranous urethral injury. That's fine. But what about the anterior urethral injury? Over here, what you need to understand is that they are going to give you a straddle injury. So what do you understand by this particular straddle injury? That is, they gave you this now, that manhole kind of cover. So manhole injury, that is what is a type of a straddle injury. Now here what they are going to have, you're going to have a superficial perineal hematoma. So somebody had kind of put a butterfly in the comment box somewhere, right? So please try to understand, it is not associated with bladder rupture. So this is also referred to as your butterfly shaped hematoma. Okay, butterfly shaped hematoma. Okay, butterfly shaped hematoma. And over here, yeah, that's what you need to understand. Here on the digital examination, the prostate is normally palpable. So this is what is your anterior urethral injury. Straddle injury, like the manhole kind of an injury in the kind of a history, and then on the examination there is a butterfly shaped superficial perineal hematoma. This is what is the anterior urethral injury, and this is what is your called as a this is what is called as your anterior urethral injury. And most common site of the anterior urethral injury is a bulbar urethra. Bicycle injury, Karan is basically trying to say bicycle. So in the olden days, what you would have seen, right? So the bicycle with the rod, right? So if at all the person or the male kind of skips or kind of falls down, what's going to happen? He's going to fall on that particular rod, and the poor urethra will get compressed between the pubic symphysis and that particular rod, and that is also a kind of a straddle type of an injury. I hope you have understood this particular point, guys. Okay, so this is very, very important. I've seen patients, students committing mistake on this day in and day out. So the urological trauma is very, very important. I hope you have understood this particular point. This is how you manage the patients of a urological trauma, guys. Okay, so guys, this is all what I wish to cover with you guys today. I'll answer a couple of questions which you guys have, and then we'll kind of call it a day. Testicular cancer and torsion. Okay, Nazir, it will be too much. Okay, so it's already 12. I think we'll kind of have a break over here. Okay, I'll cover torsion a bit, but let me just kind of put the other kind of questions what you guys have a bit, and then I'll try to talk about that a bit. Okay, so I saw a question in the options was wait and watch because the bladder was not palpable. No, it's not like that. Okay, so let's say if at all the patient is having 150 kgs of the weight, the bladder will never be palpable. Are you understand my point? So no wait and watch. Okay, so if at all there is a patient who is having an urge to pass urine, but the patient is not able to pass urine, you have to perform an RG. That is absolutely important. Okay, right. Now what you need to understand over here is okay, so yeah, so I saw a lot of questions about anxiety, not able to sleep, anti-anxiety medications, blah blah blah, all this stuff. Don't do that, guys. Okay, so please try to understand. I've already talked about this a bit. So it's not the end of your world. It is just one small stupid exam which you have to pass so that you can progress in your career. That's all that is kind of there. Okay, how to tell the obstruction level? I'm not getting. What do you understand by the obstruction level? You mean that where's the injury, whether it's a prostatic urethra, membranous urethra, pulpar urethra? That's what you're trying to say. So all you need to understand is that in the posterior urethra, this is basically at the bulbomembranous junction, and the anterior urethra, that is at the bulbar urethra. Okay, membranous part most commonly injured, the RTA, right? Okay, so in the road traffic accident, if at all there is a pelvic fracture, yes, bulbomembranous junction, Ashutosh, so that is basically a bulbomembranous junction. So abdominal incision types, okay, blades, incisions, sutures in short. Okay, so can the breast treatment confirm, please? Okay, guys. Okay, okay, I'll do that. Okay, so blades as okay, so breast treatment. Okay, so what you need to understand that if at all there's a localized breast cancer, then you can perform a modified radical mastectomy, and that's kind of done. If at all there is a locally advanced breast cancer, then you can perform a neoadjuvant chemotherapy. After that, you can perform a modified radical mastectomy. Okay, so in the mastectomy types, there is a radical mastectomy, there is a modified radical mastectomy, there is a breast conservative surgery. Modified radical mastectomy basically means that in the modified radical mastectomy, what you do is you remove the breast tissue, that's fine, you remove the lymph node tissue, excisions 1 and 2, and then depending on what you're doing to the pectoralis minor, it basically depends like what are you going to kind of do with that. Okay, so if you retract this, that is what is an Auchincloss, and the Auchincloss type of a modified radical mastectomy is the most commonly done. Finally, we have a breast conservative surgery. The important thing about the breast conservative surgery is that what you need to understand is that you do a lumpectomy. A lump is kind of removed, wide local excision is done, and along with that, you have to give a radiotherapy to the patient. That is absolutely must. Okay, you have to give a radiotherapy to these particular patients. That is absolutely must. So that is about the breast conservative surgery. Okay, right? Yeah, and what is the absolute contraindication with breast cancer surgery is pregnancy, and your what you call as one is pregnancy, another one is your so yeah, one is the pregnancy. Come on, guys, what is the other absolute contraindication? Yeah, so multifocality. If at all there is a multifocal kind of tumors in the breast, that is again a absolute contraindication. Okay, so guys, there are too many kind of things which are there, but I might not be able to kind of cover everything over here. Just stay like, yeah, okay. Okay, guys. Okay. What if there is no urge to micturate? What is the next step? So if there is no urge to micturate, then probably you're dealing with a bladder kind of rupture. Okay. Now before you guys go, what I'll be here. I'll be here for around 5-10-15 minutes. I'll cover things with you guys. But before you guys go, I just want to share my number with you guys. So what you can do is you can just drop me a text or something, and then I might be able to kind of stay connected with you guys, and you can join my WhatsApp group or anything like that. So my number is, if at all anybody wants to reach out to me, I would love to hear from you after your exams, the 54008. Okay, so this is what my number is there. This is basically on the WhatsApp. You can just connect with me. I'm Dr. Pawan. That is one thing which you need to understand. Okay, right. Okay, so okay, I'll just cover a couple of things over here. Large tumor more than 5 centimeters. So no, it is not absolute contraindication, Shivani Jagtap. That is what is a relative contraindication. What if the patient is having a very large breast? So the tumor size to the issue, that is a relative contraindication. Absolute contraindications are only two: pregnancy and multifocality. Those are the two absolute contraindications. Okay. History of the please show intestinal obstruction levels in the X-ray. Okay, got it. So Goku is basically asking, how do you tell on the X-ray whether it is a, like, what is the intestinal obstruction? I saw this particular question. This is an important one. What you need to understand is that if at all there is something which is called as a what you call as a valvulae conniventis, Ventis. Now please Google this up. I don't have the image at this point of time, but if at all you have an image of a valvulae conniventis, what is this valvulae conniventis? So these are basically the markings near the intestine. So this is predominantly present along the jejunum. So just Google this particular image. You will get to know that this was the image which was shown to you in one of the exams. So valvulae conniventis, the prominence of the valvulae conniventis, which are basically present in the jejunum. This basically tells you that there is a distal obstruction. But if at all there is a predominantly gastric dilatation, this basically tells you about the proximal obstruction. You understand my point? So this is the only thing what you can tell. You cannot actually tell whether it is a obstruction in the duodenum, jejunum, ileum, or don't know. All you can tell is whether it is a distal obstruction or whether it is a proximal obstruction. Okay, right. So I think enough of the theory matter over here. I'll just kind of give my last bits and then I will kind of tell you goodbye. So what you need to understand, guys, is that I'm sure that, like, I understand that there are a few of the doubts which I was not able to kind of cover over here, but because of the lack of time, this was the best what I could do. But it's okay, don't panic. Just kind of understand that, you know, this is just one particular exam. This is not the end of your world. You have to have some amount of anxiety, but don't let the anxiety ruin your scores. So please go with the exam with an open mindset. You're a good human being, right? So you have read whatever you have read. So it's okay. Just forget about it. Just go in the exam with a fresh mind. Whatever you know, just translate it to the paper, and whatever you deserve, you will get, provided you are present on that particular day. So just be present on that particular day and just give your 100% to that particular paper. That is what is going to help you in a good manner. Okay. Right. What should I do? Okay. So guys, that's all which I wish to cover with you guys. PDF I will share with the Dr. Bhatia team, or you can just message me. I'll kind of give you the PDF. Okay. Sure. Thank you guys. Thank you so much for patiently listening to me for the last 4 hours. How many questions to attempt? Oh no, so Diamond, there's nothing like how many questions to attempt. If at all you are, let's see, the strategy of solving the paper will be different for different individuals. Okay, so if at all you have some idea about that particular question, and so for example, you have never heard of that particular question, then yes, probably you should leave it. But if at all you have some idea about that particular question and you are pretty much sure, or you're basically stuck between the two, then you can take a plunge and you can kind of attempt it. But again, it is an individual thing, and this particular practice you would have done during your GTs. If at all you have given the GTs, then you would have done that. Okay, so this is an individual call, but I would just say that, you know what, just kind of go with the plunge. If you have read those particular stuff, then it's okay, then you can take a plunge. If at all you're kind of confused between two options, you can take a plunge. But if at all you have never heard of that particular question, then you can leave it. That's fine. So triple bubble, yeah, jejunal atresia, that's fine. How to identify such things? Okay, so forget about it. I don't think so they're going to ask you the image of a triple bubble. All you need to understand, double bubble appearance is present in two, annular pancreas as well as the duodenal atresia. Okay, so how do you distinguish between them? If at all both are given the options, if at all they give you bilious vomiting, then it is a duodenal atresia. If at all they give you non-bilious vomiting, then this is basically your annular pancreas. So please do understand this. Okay, so once they had given you the double bubble appearance and they had given both the options, duodenal atresia, annular pancreas. If at all they give you bilious vomiting, more likely to be what you call as a duodenal atresia, non-bilious vomiting, annular pancreas. Okay. What stage is if it is relieved of walking? Stage 1, we talked about it. Starts to walk, continues to walk, pain gets relieved. That is what is the stage 1. Starts to walk, pain is there, not that severe, patient continues to walk. Stage 2, starts to walk, pain occurs, had to take rest. Stage 3, stage 4 is pain at rest. Okay, right. Okay guys, take care, good night, all the best. Get back to me after your exams if at all you wish to, and yeah, all the best, will do well. Bye bye, take care, good night guys.